A very good morning to our respected chairpersons, eminent speakers, and all delegates. I, Dr. Shreya Agarwal, session coordinator for today, heartily welcomes you all on oral session on non-communicable diseases. We have with us in this session Professor Subrata Vaidya. Sir is head of Department of Community Medicine, and Agartala Government Medical College. We have Dr. Jairaj Singh Hanspal sir, Associate Professor, Department of Community Medicine, Government Doon Medical College and Hospital, Dehradun, and Dr. Sonika Sangram ma'am, Assistant Professor, Government Medical College, Kathua, Jammu and Kashmir, who are chairing this session and will be evaluating the presentations of the delegates. A very warm welcome to you all, sir and ma'am. We will start the session with the oral presentations. Uh, Professor Subrata Vaidya sir, I would like to ask your permission to start with the session. Sir, may I continue? So, we will continue with the oral presentation session. All the participants will be given a 5-minute time frame to share their slides, and after their timings is over, they will see a virtual clock going blank. It's up to the chairpersons if they want to let the participant continue their presentation or not. The question and answer sessions will be put in the end of the presentations. After all the presentations are over, now I would request Dr. Bhavna Sahani to please share her slides with us. Dr. Bhavna Sahani, ma'am.
Very good morning, everyone. Am I audible?
Yes, ma'am, you are audible.
Okay. Is my screen visible?
Not yet, ma'am, but we will wait for
Is it
you.
visible now? Is that visible now? Is the screen visible now?
Uh, Not yet, ma'am. Ma'am, kindly go to your Zoom and share screen.
Yes, I have shared screen on Zoom.
Yes, ma'am. Now your screen is visible.
Right, right.
Uh,
Yeah, can I start?
yes, ma'am. You can start
A
now.
very good morning to all the respected chairpersons and panelists. The title of my study is Seroprevalence of Anti-SARS-CoV-2 IgG antibodies among adults in District Jammu, India. Coming to the background, in J&K, the first case of COVID-19 surfaced on 18th of March 2020. Serological assays are critical to estimate the prevalence of COVID-19 antibodies. However, it yet remains to be determined whether a robust IgG response corresponds with immunity. Depending upon the level of seroprevalence of infection, appropriate public health interventions can be planned at the local level. The aims and objectives of the current study were to estimate the seroprevalence of IgG antibodies to COVID-19 in the general adult population and to study the association of risk factors for infection, including age, gender, etc. Methodology: the study setting was households in 10 health blocks of District Jammu. It was a cross-sectional study. The study unit was individual. Inclusion criteria included all people greater than 18 years of age, irrespective of recent or prior COVID exposure. Exclusion criteria included consent refusal and contraindication to venipuncture. Each participant recruited and sampled for investigation was asked to complete a schedule with the help of a postgraduate from the Department of Community Medicine. The schedule covered demographic, clinical, and exposure information. The sample size estimation was done, and the sample size was calculated to be around 2000 using an anticipated prevalence of 10% and an absolute precision of 2%. 10 health blocks, which are shown on the left side of my screen. These are the 10 health blocks. They were chosen for the purpose of the study. Out of these, 9 health blocks had both urban and rural areas, whereas Jammu city was totally urban. North, west, south, and east zones were chosen from Jammu city, and one ward each was taken from these zones. 20 to 25 households per ward were chosen randomly. And in the other 9 blocks, where we had rural and urban areas both, one village and one ward were randomly selected, and 20 to 25 households per village and ward were chosen randomly so as to achieve a total of 100 samples per day. One team from Department of Community Medicine and another team from the BMO office went for the survey. First day was used for sensitization. Second day sampling was done in village, followed by a third day sampling in wards. All the samples were taken to the Department of Blood Transfusion, GMC Jammu, and testing was done using ELISA Kavach kit having a specificity of 97.9%. The results, out of a total of 2,000 people, 164 turned out to be seropositive, which translates into a seropositivity of 8.2%. It was seen that maximum seropositivity was seen in the age group of 61 to 70 years, followed by 41 to 50 years. The rural areas had marginally higher seropositivity of 8.6%, and males also had marginally higher seropositivity of 9%. Fever, sore throat, dyspnea, myalgia, anosmia, ageusia, fatigue, and seizures were significantly associated with seropositivity. On doing a binary logistic regression analysis for risk factors, it was seen that only sore throat and myalgia turned out to be statistically significant. Regarding occupation, healthcare workers, government employees, and housewives showed maximum seropositivity. Among the 10 health blocks that were taken for the purpose of the study, it was seen that Plawala had greatest seropositivity of 15.6%, whereas Chowki Chora had the least seropositivity of 3.5%. The 8.2% seroprevalence estimate of the present study was extrapolated to the total adult population in Jammu district. 40% of the population in UT of J&K is less than 18 years of age. When we excluded this fraction from the projected population of 17 lakhs, it was observed that seropositivity of 8.2% in Jammu district translated to 85,000 cases, which was far higher than the 6,000 RT-PCR confirmed cases among adult population on 9 September 2020, which was 3 weeks ahead of the survey in Jammu district. I would like you to know that the survey in Jammu district was done on 30th September and 1st October, which further implied that for every confirmed cases, at least 13 infections were missed. The infection fatality rate was calculated by dividing the case fatality, that is 73 deaths on 9th September, by the total estimated infections of 85,000, and it worked out to be 0.08%. The findings of this survey corroborated with the estimates of the ICMR National Survey, which concluded that seroprevalence was 7.1% in August and September. It was also in corroboration with various national and international studies. This study concluded that infection has taken root in rural areas, and even if it is assumed that antibodies confer protection, we are still very far away from achieving the herd effect. The study, however, still had certain limitations. The ELISA coverage had reported specificity of 97%. Testing with greater specificity is preferred in a low prevalence setting. We might have underestimated prevalence because we actually missed clusters with higher prevalence. By selecting more than one individual per household, we again may be overestimating the prevalence. And the seroprevalence survey did not include people younger than 18 years of age. This study does not prove that those with antibodies are immune to the virus. Thank you so much. Thank you.
Thank you, ma'am. If I'm saying correct, we will be taking the questions after all the presentations are over. Now I would like Dr. Bhavna to kindly stop sharing her screen.
Yeah, sure. Thank you. Thank you so much.
And I would request Dr. Rupali Gupta, registration number 156, to kindly share her screen.
Yes, ma'am. Good morning, ma'am.
Good morning, ma'am. A very warm welcome to you.
Thank you, ma'am.
Question and session at the end, I think that will be a bit uncomfortable because we will be asking one or two questions after each presentations.
So we can take questions in between also if you are
in
saying
virtual,
this.
in virtual, the things are better if we, because we don't have the presentations ready in our head. Because when we see the presentations, better we should ask side by side. Like in AIMS, Mangalagiri also the things were the same. That we should ask one or two questions. There should be 2-3 minutes for the question session for each
Okay.
paper.
So we will do this. I would request Dr. Bhavna to be on the platform at present, and I would request sir to kindly ask the question. Uh, Professor Subrata Vaidya, sir, we cannot hear you. Could you please unmute yourself.
Yeah, it is on now. It is
Yes, sir. Audible.
audible.
Yes, sir. Yes, sir.
Very good morning, sir.
Yeah. So this is a good study you have done. Similar study we have done also in our state with a larger sample size.
Right, sir.
But nicely you have presented also, and that you have calculated this. So how you have calculated the sample size? This around 2000.
So actually, we had taken an anticipated prevalence of 10% from the ICMR survey, which had given 7.3% of seropositivity. And we took an absolute precision of 2%. And we
Okay.
used OpenEpi to calculate the sample size using a design effect of 2 and
Uh,
non-response rate of 15%. Yeah.
Design effect you have taken.
Sorry, sir.
Design effect you have taken.
Sir, we have taken, but actually, what happened is, I would like to tell it very honestly. We were given just 3 days to plan this survey, and we had to finish this survey in 2 days. So we could not go in for a higher sample size greater than 2000. We
No, no,
had
I am
taken,
telling that if you take the design effect too, actually that is taken for the cluster sampling. What
yes, sir,
sampling you
yes,
have
sir,
done?
yes, sir. We have not done cluster sampling, to be very frank. But
Yeah,
what we did was we selected blocks, and from the blocks we selected one village and one
some sort of
ward.
stratified sampling.
Yes, kind of, kind of. So it's a mix of all samplings because we
Hmm.
had to achieve a sample size of 2000 and we were given very less time to prepare for the survey, just 2 days. So it is not
So,
exactly cluster sampling, it is not exactly stratified too. It's a mix of both. And it was
but
basically done according to the convenience of the BMOs also.
okay. So that's good study, and I should give a big thanks because we are
Thank you
also
so much.
trying to publish our. For us, it is more higher seropositivity rate. Around it is 36% in our state, Tripura.
Right.
Okay. So thank you from my side.
Thank you so much, sir. Thank you so much. Thank you.
Now I invite Dr. Jairaj Singh Hanspal sir to please ask the questions.
But I am saying that you know the quality of the topic and the quality of study is different. Here I am seeing that which you have told yourself also that you were too hurry in making the paper or doing the study. The thing is that the study, the topic, the work is really very very important, especially nowadays also. But the thing is that you were too hurry in making the study. Is it
Right,
so?
sir. So
Is
you're
it so?
absolutely right. We were given just 2 days to plan and execute everything.
But the thing is that, especially in our community medicine, the quality matters.
Right, sir. Right,
Whenever we
absolutely.
make the things, the data we present, that matters a lot.
Right, sir.
Just taking this type of study, that too in a hurry. I'm not saying that
Sir,
this study
actually,
is
this
not
was the
good.
first study which was done in Jammu region. We had nothing,
That is
no background data,
I know, I know.
and we had no estimates to fall back on. So this was the first study which was planned. And yes, sir, we are doing serial testing also now, and we are taking this forward with a more
Yeah,
methodological approach, which
this is
would be more
what I have
scientifically
to.
sound.
You should redo this study because I know the condition of Jammu there. There
Yes,
is a
sir.
limitation to studies. Very
Right,
few studies are done in most of the areas. I know.
right, sir.
Recently, the Jammu region and Kashmir region is developing,
Right,
especially with respect to the data and all these things, due to some political limitation and whatever reasons.
right, sir.
But the thing is that now, since the study is good,
Right,
you
sir.
should take help of your professors and you redo this study
Right,
with
sir.
more quality in it.
Ji, sir. Ji,
It
sir.
is more of a I can see that it is just completing for the seminar, for the conference. So
Right.
please do the study. Otherwise, approach is good, but hard work is lacking.
Sir, actually, at the block level, we had so many teams, and the data which was collected was done very precisely. We did not miss
I
one sample.
see. Not only at your end, at every end,
Right,
because
right.
it's a teamwork. Study is a teamwork. It's
Yes,
not
sir.
something
Yes,
that
sir.
you go and ask one person and your study is done.
Yes, sir.
It is a teamwork. You have to take help of your seniors, your subordinates, your health workers, and all these things.
Right, sir.
Okay, thank you.
Thank you, sir. Thank you.
Thank you, sir. Now I would invite Dr. Sonika Sangra ma'am for her questions.
Hello.
Yes, ma'am,
Hello.
you are
Good
audible.
morning, Dr. Bhavna Sahni.
Good morning,
Yes,
Dr.
ma'am.
Sonika. How are you?
Ma'am, I'm fine. Ma'am, was there one more question is there about the methodology part. Only 2,000 sample, but the Jammu district, how many population is there?
Sonika, you're not audible, Dr. Sonika. Your voice is cracking. I cannot hear you.
Okay. Ma'am, just only 2,000 population is a very less sample size. 10 blocks and only 2,000 sample size.
Yes. Yeah, I
Just
told.
this one question
Yeah,
only.
Dr. Sonika, the prevalence, anticipated prevalence
Yes,
was
ma'am.
10%.
I'm from GMC. I'm from Jamuna, then that's why.
Yeah. The anticipated prevalence was taken as 10%. Yeah. And absolute precision was
Yes,
2%. In
ma'am.
open epi, when we calculate, we get it around 1800. And using a non-response rate of 15%, we stretched it to 2000.
Ma'am, how you will divide into the rural and the urban
Yes,
areas
we had taken
about
list
the
from
fertility?
Dr. Sonika. We had taken list from the BMO
Ma'am,
office, and it was the BMOs who had given us the list, and
ma'am.
one village and one ward were randomly selected from the blocks. We had a whole list of all the
Okay,
villages
okay.
and wards. Yeah, all lists were made. They
Okay,
were
ma'am. Thank
yeah,
you,
and
ma'am.
random sampling was done there. Randomly, one village and ward
Okay,
was
ma'am.
selected from each block. Yeah, thank you.
Okay, ma'am. Thank you, ma'am.
Thank you.
Thank you.
Thank you, Dr. Sonika Sangra. Thank you, Dr. Bhavna Sahani.
Thank you so much.
Thank
If
you.
there, now I would request Dr. Bhavna Sahani to kindly stop sharing her screen.
Ma'am, my screen sharing is already paused. Is it fine now?
Okay.
Yeah,
Now,
thank you.
yes. Thank you. Now I invite Dr. Rupali Gupta to please share
Yes,
her
ma'am.
screen.
Yes,
Dr.
ma'am.
Rupali
Yeah.
Gupta, yes. Dr.
Yes.
Rupali Gupta has registration number 156.
Yes, ma'am. Yes,
Come,
ma'am.
ma'am.
Ma'am, my screen is visible to you all.
Yes, visible.
Yes, ma'am.
Okay. Should I continue?
Yes,
Should
please.
I
Yes.
start, ma'am?
Yes, you can.
Okay.
Yes.
Okay. Thank you. Good morning, respected teachers and my colleague and my seniors. Myself, Dr. Rupali Gupta from the Department of Community Medicine, GMC Haldwani, and the topic of my study is a study of depression among OPD patients of rural areas of Haldwani, district Nainital. Coming to the introduction, one of the most common mental disorders affecting the modern man is depression, which amounts to 121 million individuals worldwide, and it frequently goes unrecognized. As per the global burden of the disease 2000, depression is the fourth leading contributor causing disability, which is measured by year lived with disability. Depression accounts for 5% of the total burden of the disease from all causes. 25 to 33% of the patients treated in primary care setting have a mental disorder. Depression, anxiety, and alcohol use are the commonest disorders in a primary care setting, contributing to nearly 20% of the caseload, but only a small percentage of these is recognized and treated. The objective of my study was to estimate the prevalence of depression among OPD patients of rural areas of Haldwani and to find out the association between socio-demographic profile of the patient and depression. Coming to the methodology, it was a cross-sectional study conducted among the 200 OPDs attendees from the Rural Health Training Center of Mota Haldu of the Department of Community Medicine, GMC Haldwani, from the study period from 15 January to 15 February of the year 2020. The data collection. It was a pre-designed questionnaire was prepared on EpiCollect 5, and the data was collected by using EpiCollect 5 software And the scale for depression used was Center for Epidemiology Studies Depression Scale Revised, that is CESDR-10. Confidentiality of the participants were assured, and the data was analyzed by using SPSS version 16, and chi-square test was applied, and p-value less than 0.05 considered as significant. Some point about the Center for Epidemiological Study Depression Scale Revised. This is a scale. This scale is a self-report measure of depression, and it has 10 items. Any score equal to or above 10 is considered as depressed. Now the results, the table 1 showing the socio-demographic profile of the patient. In this my study, most of the patient belongs to the age group of the 10 to 30 years, that is 43%. Most of the patient were female, that is 64.5%. Most of the patients belongs to the Hindu religion, and the p-values is found to be insignificant. That is 0.028. Most of the patients belongs to the and the p-value is found to be significant, that is 0.028. Most of the patients belongs to the upper lower class, that is 57.5%, and most of the patient belongs to the nuclear family. And the p-value is found significant only in the education part, that is 0.028. In the rest of the variable, it is insignificant. This is the figure showing the prevalence of the depression according to the age. You can see most of the patient, the depression was found to be maximum among the age group category of 31 to 50, that is 42.85%, followed by 10 to 30 years, that is 40%. And among 51 to 70, and the data I have collected is only 14.3%, and among 71 to 90, I have seen only 2.85% of the individual was found to be depressed. This is the table showing the prevalence of depression according to the gender. In my study, females affected more as compared to the male, and out of total 35 individuals, that is 17.5%, 17.8% were female, and 16.9% were male. And the p-value is found to be insignificant, that is 0.869. Now, conclusion and recommendation. The prevalence of depression was found to be 17.5%, that is 35, as female affected more in this study, and significant association was found between literacy rate and depression. So there is a need for screening the signs and symptoms of depression among females. Education and awareness programs can be organized in the community as well as at the health facilities. These were my references. Thank you.
Thank you, Dr. Rupali.
Thank you.
Now I would like to invite Professor Subrata Vaidya sir to please ask the questions.
Yes, ma'am.
I invite Dr. Jairaj Singh Hanspal sir to ask questions. I invite Dr. Sonika Sangra ma'am to
One
ask.
minute, actually, my
Okay.
phone.
Yes. Sorry, sir.
Pali, I just
Yes, sir. Yes, sir. Good
ask
morning,
you,
sir.
you will
Yes,
rate
sir.
the quality of your study. You are a faculty.
Yes, sir.
You are a faculty at Haldwani.
No, sir. I am PGJR2, sir.
JR2. Okay.
Yes, sir. Yes,
As a
sir.
JR2,
Yes,
how
sir.
you will rate the quality of your study?
Sir, I can improve the sample size. Actually, sir, I have done this study in 1 month of time, because after that, our center was sir, changed into the COVID care center, so the OPD was closed. And at that time, sir, in that time, I have could collected only 200 OPD patients. Actually, I could improve my sample size.
That is the question. As a JR2 also, how you will improve?
Yes.
Like what was lacking? That only you will improve. First, you will be knowing
Yes, sir.
what is the lacking in your study as a community medicine.
Uh, Sir, one thing I have told, sir, I can improve the sample size because it's very small, and sir, other parameters I can take, sir.
That is the
Just
thing.
I,
Sample size
yes, sir.
of
Yes,
course
sir.
there, but sample
Yes,
size
sir.
also if you take 4 times,
Yes, sir.
But
Yes, sir. Yes, sir. Yes,
this
sir. I agree, sir. Yes, sir.
depression, I didn't find
Yes,
any
sir.
deep thing in this.
Yes,
Like
sir.
in our department, our PG1
Yes,
also
sir.
we used to tell them in beginning.
Yes, sir. Yes, sir. Hello. Yes, sir.
Just a common parameter, no cross tables, detailing of
Yes, sir.
depression.
Yes,
So
sir. Actually, I prepared these slides in very short period of time, sir.
this was
And
lacking.
yes, sir.
You can study more, quality part, and more
Yes,
rich.
sir.
It's a
Okay,
very
sir.
important study, nowadays, of course.
Yes, sir. Okay.
Dr. Shreya, you may continue. I have
Thank you, sir. Dr. Sonika Sangra, ma'am. Ma'am, if you have any questions, you can please put up your question.
I think her audio is switched off. So
Hello, Dr. Rupali.
Yes, ma'am. Should I stop here, ma'am?
Dr. Rupali. Yes.
Yeah. Okay, ma'am.
Yes.
Yes, ma'am. Good morning,
Yes.
ma'am.
Yes.
Good morning, ma'am.
Good morning. Good morning, Dr. Rupali. In any
Yes, ma'am.
comparative study, why you didn't done the study in your community-based study? Any comparative study between the why difference between the hospital-based and the community-based?
Ma'am, your voice is not very clear to me. Can you pardon, ma'am, please? Yes, ma'am.
Okay. Any study on the community-based study? Any
Yes,
study?
ma'am. Yes, ma'am. Ma'am, this is a community-based study. I've done this in at rural areas of Haldwani, ma'am. And because I want to know the ma'am depression that is unrecognized depression among the ma'am our rural areas. That's why I've done this study in my rural areas, ma'am. But ma'am,
Okay.
ma'am, limitation is the limitation of my study was I have taken the very small sample size because of the lockdown, and ma'am, my
Me
center
too.
that
I
is
did.
yes, ma'am, and because after that my center was converted into the COVID care center, and the OPDs was closed after that. So I didn't get more samples, ma'am. So I have to stop this study, and even now my COVID care center is running, and OPD is ma'am closed till now, ma'am. That's why I have not
Oh,
ma'am
okay.
collect more data on this. Okay, ma'am.
Okay. Thank you.
Thank you, ma'am.
Dr. Sonika Sangra, ma'am, and thank you, Dr. Rupali Gupta.
Thank you, ma'am. Thank you.
Ma'am, I request you to thank you, ma'am. Now I invite Dr. Kamna Singh to please share her screen. Dr. Kamna Singh has registration number 146. Ma'am, you can start with your presentation. Thank you.
Coming to the introduction, insomnia is one of the common but neglected conditions seen in family practice with long term and serious effects on health. Various studies worldwide have shown the prevalence of insomnia in 10 to 30% of the population, some even as high as 50 to 60%. Objective of a study was to determine the prevalence of insomnia among adults aged more than 30 years living in rural area of Jammu. Coming to the methodology, It was a hospital-based cross-sectional study carried out at Community Health Center Alaspura over a period of 3 months. Study participants were the attendants accompanying patients in CSC Alaspura aged more than 30 years who agreed to participate in the study after giving informed verbal consent. Study tool used was Insomnia Severity Index, and data analysis was done using MS Excel. Coming to the results, this table shows the social demographic profile of the study participant. Majority of a study participant, that is 31.3 percentage, were in the age group 30 to 40 years, followed by 27.1 percentage in the age group 51 to 60, and there were only 10 participants in the age group more than 70 years. Out of the total 217 participants, 127 were females and 91 were males. Educational status, 23.50% of the participants were illiterate, whereas 30.8% had the educational level up to the middle level, whereas only 9.2% were graduate. Occupation, 25.8% were farmer in a study, 10.13% were doing government job, and only 17.05% were into the private jobs. This figure shows the distribution of the participants as per insomnia severity index used. 62.2% of the participants had no clinical significant insomnia. 50.2% of the participants had subthreshold insomnia, whereas 5.52% had clinical insomnia of moderate severity and 6.4% had clinical insomnia of severe severity. Discussion. B. Swapna et al. Reported prevalence of insomnia in 33% of the adult population sample, which was comparatively higher than our study. The overall prevalence of insomnia among university students was found to be 19.3% by Osama et al. Concluding my presentation, overall the prevalence of insomnia in the present study was found out to be 11.97%. Majority of the participants were found to have subthreshold insomnia. Thus, further research work is needed from time to time to assess the underlying reasons for the same. Thank you.
Thank you, Dr. Kamna ji. Professor Dr. Subrata Vaidya, sir, to please
Yes.
comment on the presentation.
Yeah, that is, I have seen the study. Basically, this is a, I am audible, no?
Yes, sir, you are audible.
Hello.
Good morning, sir.
Yeah,
Yes,
you
sir,
are
good
audible.
morning.
Basic, good morning. This is basically hospital-based study, but you could have done in the community,
Yes, sir.
because in the hospital-based study, the people are coming for the different clinical condition, anxiety, so it gives more burden of the insomnia.
Yes,
So I
sir.
think we should go to the community with the proper sampling so that it can get a good external validity. Then you can generalize this with the other population, similar population.
Yes, yes, sir.
So that's my point. Okay. Thank you for nice presentation.
Thank you, sir.
Thank you, sir. Now I invite Dr. Jera Singh Hanspal, sir, to please comment on the presentation.
What was this severity index, insomnia severity index, and when this index was made? With respect to this index, why? What were the you have taken from the rural study? Does this apply to the rural study? The severity index?
No, sir. Hello? This is for, sir. Hello?
Yes, yes, I can hear.
Yes, sir. No, sir. This applies to all rural and urban area. But actually, I was posted in the rural area, so I conducted the study over there using this index.
This index was more in the urban areas, not in rural areas.
Okay, sir.
So I can feel it. What were the how you have rated the insomnia in your patient, like 19.3% or 11 point something? You said that how many insomnia cases came into the study?
So there were
11% or say 19%, like that?
these are the results. 12 patients had moderate severity clinical insomnia and 14 had severe clinical insomnia.
How you will rate this? how you have taken
So,
out the that,
so this index had scoring system.
yeah,
This this index had given the scoring system was 0 to 6.
parameters, actually the parameters in the insomnia severity index,
Yes, sir.
parameters which they have used that apply mostly in the urban areas. In Indian rural areas, with the help of this index, you could have made the table which applies to the rural area of India, because
Okay,
the
sir.
reasons are very different. We
Yes, sir.
cannot go for West study or West indexes in our studies in most of the cases. We can take help of those index, and we can modify so that we get a better results.
Okay, sir.
The thing is this, that is why you have you have made the study, you have shown the results. Now what further? What you will do with the results?
So we will now see the association between the socio-demographic factors and insomnia
That
further.
you have done and presented. That is the
No,
quality. That is the quality.
yes, sir.
Going and find the cases and how you have selected the sample,
Hello, sir. We have done convenient sampling the attendance of the patient coming to the hospital.
and why this 200 figure came to your in a study, exact 200,
It's not sir 200, 217.
217.
Yes, sir.
Okay. And what about the age groups? Like
So
you have taken more than 30 years.
more than 30 years.
So anyway, though this study is good, but the thing is that the what I am seeing, the lacking factor more of a presentation rather than it should come up with the things. Na, see, my study has this thing, so it can make maybe at the demonstrator level your limitations are there, but you can take help of your seniors and make
Yes,
this
sir.
study a quality study.
Okay, sir.
There should be a big difference between a community medicine study and a different study. Most of the
Right, sir.
clinical people they present like this, but ours should be, it should matter. The study should matter. That is why
Yes,
when
sir.
I was PG some 20-25 years back, my professor used to say always that whatever you are doing, it should matter the society. It is not simply like that. Anyway, thank you.
Okay, sir. Thank you.
Thank you, sir. Now I invite Dr. Sonika Sangra ma'am to please comment on the presentation.
Dr. Shreya, you may, Dr. Shreya,
So I will continue with the next presentation.
Dr. Shreya, you may please
Okay.
tell the participants during the question hour session that they should switch on their video. That will be more decent way to ask the questions.
Okay, sir. I request all the presenters to please put their video on when their presentation is going on and during the question hour session. Thank you, Dr. Kamla Singh. Ma'am, please, I request you to kindly stop sharing your screen.
Yes, ma'am.
Thank you, ma'am.
Ma'am, wait.
Now I invite Dr. Prashant. No issues, ma'am. Next, I am inviting Dr. Prashant Kumar Dikshit to kindly share his screen.
Am I audible? Hello.
Yes, sir, you are audible. Your screen is visible. You can
Okay.
go for slideshow.
My title of my study is Prevalence, Awareness, Treatment, and Control of Diabetes among elderly persons in an urban slum of Berlin. Introduction: Diabetes is a common non-communicable disease in India as well as the rest of the world. The estimate of prevalence of diabetes is estimated at nearly 3% of elderly with diabetes in the year 2000, and in the year 2000, this figure is projected to be nearly doubled by the year 2030. Diabetes also contributes to 5% of the total mortality. Recently, India has witnessed this demographic transition with a reduction in crude birth rate and increase in life expectancy. In spite of its high prevalence and being a major cause of mortality, diabetes remains highly undiagnosed. Undiagnosed diabetes is associated with increased risk of all-cause mortality. Delayed diagnosis and inadequate or improper treatment will result in poor disease outcomes. Methodology: This was a cross-sectional community-based study among elderly persons aged 60 years and above in an urban slum in Gwalior city, Madhya Pradesh, India. 250 elderly persons were included in the study, resided in Madagaon, Kotigaon, Lakshmanpura, Awalpura, Jalnapura, all are urban slums in Gwalior city. All eligible elderly persons were recruited to the study. The participants were eligible if they had been residing in the study area for at least the last 6 months and were able to comprehend the question. Data were collected by house-to-house visits during September 2019 to January 2020. All participants were interviewed in the local language at their homes. Inform, uh, Information on socio-demographic variables via age and sex and treatment history of diabetes was reported. Fasting blood sugar was estimated by using an one-touch select plus test strip. Diabetes was diagnosed if the fasting blood sugar glucose was more than 136 milligram per deciliter after an overnight fast for at least 8 hours, or if the participant was taking treatment for diabetes. Impaired fasting blood glucose was diagnosed if fasting blood glucose was 110 to 125 milligram per deciliter. Data were entered in Epi-Info software version 3.5. Statistical analysis was done in Stata version 9. Proportions were calculated with 95% confidence interval and chi-square test was applied. The study was approved by the Institute Ethics Committee. Written informed consent was taken from the participants. Results: a total of 250 eligible elderly persons were interviewed for the study. The mean age was 62 years. Of the 250 participants who were interviewed, 22 refused for fasting blood sugar estimation. None of these 22% had any prescription for anti-diabetic medicine. 71% of the participants were male. About 4/5 of the participants were aged less than 70 years. Shown in Table 1. In Table 1, demographic characteristic of the participants whose variables are in age group 60 to 64 years, 65 to 69 years, and more than 70 years. Men, overall total number of men is 177 and women 73. About one third, 36% of the 59 diabetics were aware of their condition. Awareness, treatment, and control were better among women. However, this was not statistically significant. Of those participants who were aware, more than half were on treatment. Of those on treatment, three-fourths had controlled fasting blood sugar. And shown in table 2. This is table 2. Participants with diabetes who were aware, treated, and controlled. Out of total 59 were diabetic. Out of them, 22 were aware, 13 were treated, and 10 out of them were controlled. Discussion: the aging of population in India is likely to lead to an increase in the prevalence of diabetes. The prevalence of diabetes was estimated to be 18.8% in the present study. A study from India have reported a prevalence from 13% to 25%, which is comparable. Study from other Asian nations such as Thailand and Hong Kong were referred to the lower prevalence rate of 14% and 15% respectively. Decrease in the prevalence of diabetes with increasing age in the present study could be due to survival bias. Awareness of the diabetes was found to be among the participants of the parent study, only 36% were aware of their condition. This is low with that reported from the Hong Kong and compared to the one third from Nepal. Conclusion: screening, diagnosis, and proper treatment of diabetes is required for elderly persons because they may be unable to visit the phased health facility due to dependency on family members, etc. Domiciliary visits by health staff may be considered for creating awareness and screening of this condition. The screening test for diabetes is relatively easy to perform. The training of health workers in screening and appropriate referral is a feasible option. Strengthening primary health care services in urban slums with special emphasis on the vulnerable population like elderly person is needed. Non-communicable diseases are a major cause of morbidity and mortality in this age group and deserve special attention of policymakers and program managers. These are the differences. Thank you.
Thank you, Dr. Prashant.
Yeah.
I invite Professor Subrata Vaidya sir
Uh,
to put up his
Hello.
questions.
Yes. This is he tried to do something, but clearly could not tell what was the basic research question, what he want to see. And I think there are objectives also. There are multiple objectives, and sample size calculation also I didn't find. So can you just explain this fact?
Sir, this is simple random sampling, and which
Sample how you have come to 250?
250, sir, if convenient for my convenience, I take
Convenient.
250 samples.
So once
Yes, sir.
once you take the convenient sampling,
Yes, sir.
then in that case the sampling technique, the probability sampling technique, you cannot. What is the need for the probability sampling taking? So when you take convenient sampling, so
Yes, sir.
it is better just do it like this, but try to do the sample size calculation. So better understanding of the problem. Now you could have taken the whole area, then taking the sample size calculation, then
Yes, yes, sir.
simple random sampling technique, and lot of objectives you have, the questions you try to find out.
Yes,
So,
sir.
but basic, what was your intention to understand, and what is the nobility of your study? That something new, because that we know, but something has not been done in that population. So you should have come out with that new concept, because research always gives new things. Okay,
Yes, sir.
maybe uh, that prevalence among this elderly population, maybe their health seeking behavior proper way. So like this you could have taken. Okay, so try the next with the just modification of the
Okay.
your protocol and all.
Yes,
Okay,
sir.
thank you
Thank,
from my
thank you.
side.
Thank you.
Thank you, sir, for your guidance. Now I invite Dr. Jairaj Singh Hanspal sir to put up his questions.
Dr. Prashant, where are you? Can I see you?
Yes, sir. Hello.
Dr. Prashant, where are you?
Doc-
Can I see you in video?
एक मिनट sir.
Okay. Anyway, like sir has already asked you that sample size you are there to, you are a
Yes, sir.
post,
Yeah.
you are a postgraduate student.
Yes, sir. Postgraduate student, sir.
Did you show your study to your professor and seniors?
Yes, sir. Seniors, I saw my study.
Why everybody is taking as per convenience, you know? In our times, there was nothing known as per convenience. As per convenience was the last resort when in this world or in this universe, we are not finding any way how to make our sample size. So
Yes, sir.
after that, you know, we had to think about the convenience part. And nowadays, PG students, they start with the convenience. How the quality of the study will come? I am really surprised, sorry to say, that your professors, if you have shown to them, they are approving this. And that too, that study where lakhs of this thing, study has already been conducted in this world. So why have you taken by convenience? Why it was such that you cannot take any sample size, or you don't have any, you know, data or any other parallel study which you can make use of?
सर
Why
250 सैंपल
convenience?
ही सर मुझे 254 सैंपल टोटल मिले थे तो उसमें से 250 मैंने मतलब सिलेक्ट किए हैं टोटल ओवरऑल
नहीं नहीं, पर कोई मेथड तो होना चाहिए ना। मिले ठीक है, वो एक बात होती है, पर एक सैंपल साइज की कैलकुलेशन होती है, वही एक मैटर करता है कम्युनिटी मेडिसिन में। कैसे थोड़ी ना कि आपको ऐसा एक मैजिकल फिगर आया कि चलो या मैं देखते जाता हूँ जितना में मिल गए।
नहीं
यू
सर
डोंट,
मैंने और भी रेफरेंस में 2-3 स्टडी मैंने फॉलो की थी तो
आपने कौन से स्टडीज फॉलो करी है? आप तो नेपाल और हांगकांग का डाटा बता रहे हैं, तो भगवान की कृपा से हमारे यहाँ तो डायबिटिक सेकंड नंबर पे आ रही है वर्ल्ड में।
जी सर
हमारे यहाँ तो इतना काम हुआ डायबिटिक का, मैंने ही खुद कितना काम किया है।
जी सर
तो आप हांगकांग और नेपाल का डाटा बताएंगे, जहाँ का खासकर नेपाल का देखें तो हेल्थ सर्विसेज कहाँ जा रही है, और जो भी हो रहा हो, अच्छा हो खराब हो, बट यू शुड टेकन द रेफरेंस ऑफ इंडियन स्टडीज। दैट इज व्हाट आई एम सीइंग इन योर रेफरेंसेस आल्सो। Where does Hong Kong and Nepal you can compare with India? तो इस तरह से प्रेजेंटेशन नहीं करनी चाहिए बेटा when you are in the national forum, you know. And especially we are also, when we were in PG2, you know, we would have been literally squeezed before presentation because you are representing a college, you are representing yourself. इसमें काफी कुछ ऐड किया जा सकता था. क्वालिटी का तो चलो छोड़ दीजिए, वो तो ठीक है PG2 लेवल का जो हो, बट जो बेसिक्स होते हैं. आपने डायबिटिक किनको लिया है? जो 126 एंड अबाउ 126 वाले को डायबिटिक ले लिया.
126 above, sir. The fasting blood sugar
डायबिटिक
126
होता है
and
इंडिया
above.
में.
The fasting more than 126 and a PP more than 200.
अच्छा, बीपी मोर देन 200. अच्छा, मोर 200 जो है डायबिटिक नहीं होता इंडिया में.
The 200 मतलब 200 and above diabetic आते हैं.
वही, दैट इज माय क्वेश्चन ना. अबाउ में मैं जा ही नहीं रहा हूँ. 200 इज डायबिटिक, योर पीपी इज 200, you will
Yes, sir,
simply
diabetic.
relax.
Sir, diabetic.
Then उसका क्या है? 200 कौन सा आपने डाटा से लिया है वो भी मैं समझ रहा हूँ. उसका एक इंडिया में हो चुका है कि नहीं? डेट डिसाइडेड हो गया कि नहीं इंडिया में कि जो 199 हुआ, 200 हुआ तो चलो आराम करो यार, कुछ नहीं करना, यू आर नॉट डायबिटिक.
नहीं सर, वो प्री मतलब लेस देन 200 प्री डायबिटिक में आ जाएगा.
हैं?
प्री डायबिटिक रेंज में होंगे सर, लेस देन 200.
लेस देन 200 प्री डायबिटिक.
मतलब 110 to 125 प्री डायबिटिक्स की रेंज में रहेंगे सर.
स्टैंडर्ड कौन सा है जो इंडिया में आज भी इस्तेमाल हो रहा है? 200 तक हो रहा है क्या? सी दिस इज व्हाट यू हैव टू स्टडी, यू नो. मुझे ये नहीं समझ आ रहा है. आप इंडियन कॉन्टेक्स्ट के साथ बात करें. यू डोंट गो अबाउट हियर एंड देयर एंड वेस्ट एंड ऑल दिस. सबका सिनेरियो बहुत अलग है, खासकर नॉन कम्युनिकेबल में. ठीक है, यू शुड गो अबाउट इंडियन. यू हैव टू स्टडी इंडियन स्टडीज, इंडियन डाटा, इंडियन लिमिट्स. तब होता है ना ये सब चीजें. तो ये एक बेसिक चीज है कि आपको चीज. और आपने जो 22 लिए हैं उनको आपने कैसे इंक्लूड किया है जब ना उनके पास प्रिस्क्रिप्शन है, ना वो फास्टिंग के लिए एग्री कर रहे हैं? तो आपने क्या उनमें देखा कि आपने उनको अपनी स्टडी में इंक्लूड कर लिया?
सर वो मतलब उन्होंने बताया वो डायबिटिक है, पर उनके पास मतलब पहले दवाई ली होगी, पर उनके पास कोई प्रिस्क्रिप्शन नहीं थे पहले. मतलब अभी
आपकी स्टडी की क्वालिटी सिर्फ बोलने से चल जाएगा क्या? जहाँ पे कोई चीज आपके पास प्रूफ होनी चाहिए. व्हाई हैव यू इंक्लूडेड दोस पीपल वेयर देयर इज अ डाउट? हो सकता है कि वो कहें कि नहीं, अच्छा वो नहीं था हमारे पास डायबिटीज, वो मेरे को हाइपरटेंशन था, मैं थोड़ा कंफ्यूज हो गया था. फिर आपको वो दवाइयां दिखा नहीं रहे, प्रिस्क्रिप्शन दिखा नहीं रहे, फास्टिंग कर नहीं रहे. तो ऐसा कौन सा फैक्टर हो गया जिसमें आपने इनको इंक्लूड किया? यू कुड हैव एक्सक्लूडेड दो स्टडीज, क्योंकि वो 22 से आपकी स्टडी खराब करेंगे.
सर उनको एक्सक्लूड तो किया है सर, मतलब मैंने रिफ्यूज ही तो किया है सर.
क्या चीज?
सर उनको रिफ्यूज ही तो किया है मैंने सर, उनको मतलब इंक्लूड कहाँ किया है?
उनको अपने एक्सक्लूड किया है?
जी सर, आप एक बार फिर से देख लीजिए.
अच्छा, ठीक है, फिर मैंने
उनको मतलब मैंने सर रिफ्यूज किया है.
आप समझ रहे हैं जो चीज पे मैं फोकस कर रहा हूँ?
जी सर.
ये आप करके इसको अच्छा बनाइए ना.
जी सर, मैं
डायबिटिक का तो और करना है
सर नेक्स्ट टाइम और अच्छे से
सिर्फ प्रेजेंट करना है इसको. इसमें वजन डालिए जिसको कहते हैं ना स्टडी में.
जी सर.
और कन्वीनियंट मत करिए स्टडी को करिए, सैंपल साइज कैलकुलेट करिए, सैंपल साइज बनाइए. कितने तरीके हैं सैंपल साइजेस के, और आप कन्वीनियंस वर्ड मत यूज करिए.
ओके,
चलिए, ओके. That's all from my part, Dr. Shah.
Thank you, sir. Thank you for your guidance. I invite Dr. Sonika Sangra ma'am to provide her guidance for this study.
Hello, Dr. Prashant.
Yeah.
Dr. Prashant, I'm audible?
जी मैम audible.
Okay. Just one question. What is the disadvantage of using the convenience sampling?
Actual sample size नहीं, मतलब
हाँ, कुछ नहीं है बच्चा, इसमें बाइसिंग हो जाएगी. ठीक है ना? ठीक है, चलो, ओके, थैंक यू.
Thank you, ma'am. Thank you for your guidance. I request Dr. Prashant.
Thank you, Dr. Shah.
Thank you, ma'am. I request Dr. Prashant Dikshit to kindly stop sharing his screen.
Okay.
Thank you, Dr. Prashant. Now invite Dr. Smita Asthana to kindly share her screen with us. I welcome you, ma'am. Kindly unmute yourself. Ma'am, you are ready to grow. Ma'am, kindly unmute.
Am I audible?
Yes, ma'am. Ma'am, you can
Is my
start with your
screen visible?
presentation. Yes, ma'am.
So I want a full screen. Yeah. So should I start? Good morning, everyone. I am Dr. Smita Asthana from ICMR and ICPR. And today I am going to present on my work on association of smokeless tobacco use and oral cancer, a systematic global review and meta-analysis. And this study is a part of our institute's global knowledge hub, because our institute is a part of global knowledge hub, and it working in association of WHO and other various other collaborations. And this study is a part of that. So you know that tobacco, one thing is like oral cancer, everyone is aware, is one of major cause of morbidity and mortality across the globe, and it's one of the most important cancer, and as well as the role of tobacco as a etiological factor for developing oral cancer is obvious and everyone knows about it. But at the same time, the role of due to, you know, that smokeless and smoking, if we divide tobacco in two parts, smokeless and smoking, so the studies on smoking tobacco is quite obvious, and due to it's more used in Western countries, there is focused work on smokeless. And in the process, the importance of smokeless tobacco is demeaned and as a causative for factors for various diseases. And like this study focus on the role of smokeless tobacco on developing oral cancer. So our main objective is to assess the association between exposure to different smokeless tobacco products and the risk of oral cancer at global level. And through a systematic review and meta-analysis, regarding methodology, we followed the PRISMA guidelines, and PRISMA chart was prepared. The literature search was as everyone knows, like it was not on just one investigator has done. Two investigators independently conducted the literature search, and various database were searched, PubMed, InMed, Google Scholar, Embase, hand searches, etc. database were searched, and along with cross references. And such studies was relevant keywords such as smokeless tobacco and oral cancer, along with various specific tobacco products like gutka and canny and each jarda and all individual smokeless tobacco product with appropriate Boolean operator and in the form of and or strategies applied. And specific inclusion and exclusion criteria were adopted for the search of relevant literature. So we included studies that are at least one confounder is adjusted, that is smoking at least. We have checked a thorough quality check for the studies, and only case control and cohort studies are included in, not the cross-sectional studies in this. And the studies that has appropriate comparison group is taken into consideration. And then the Prisma chart, we got on all the searches, we got around 4,847 hits. And then after applying the inclusion and exclusion criteria and removal of duplicates, the ultimate number that we reached upon was 37 studies, and which has given us 61 estimates of various subgroups or factors. And regarding data summarization was done according to WHO's regional classification. That was because this is a global, so all the continents according to WHO where we get the study, we try to summarize that. And for all the primary study, these what are the specific data collection were on study location, period of study, study design, sample size, setting, and case or expose factor, what were the non-exposures, comparison groups, confounder adjusted, matching, whether matching done or not, and the risk estimates were tabulated. And subgroup analysis was done on WHO, various WHO regions, study designs, SLT product use. So this is very important, like whether the SLT product use were chewable or not chewable. And apart from that, individual smokeless tobacco project like gutka, canny, pan tobacco, manpuri tobacco, individual itemized summarization is also done. And then the gender specific subgroup analysis is also done. Year of publication 1990 was taken as cutoff, before 1990 and after 1990 subgroup analysis, and whether the studies were adjusted for age and non-age comparison in between the two. Meta-analysis was conducted on Raveman 5.3 package. For forest plot, used the randomized effect model because of there were a lot of variation between the study, and the effect size was the odds ratio along with 95% confidence interval, and the heterogeneity was analyzed using I-square method. So study record selection according to study location, period of study, that I already explained. Now this is, sorry, this is some. Now on Raveman, this type of fun plots, this is an example of one of the forest plots, and you see it is showing different geographical region, like here Eastern Mediterranean, European Americas, and similar type of subgroup analysis on different estimates are given. So these are the main results in according to subgroup analysis. So you can see that overall risk estimated in all the WHO region was around 3.57. And if we look at the region-wise analysis, so Southeast Asian region has 4.4, and this is a significant risk. Though America also has similar, but this risk is most significant risk in Southeast Asian region. Then European region has least risk. Females has more risk as compared to male, is 5-fold risk as compared to 2-fold risk. Chewing tobacco products had more risk, 4.3 as compared to non-chewing, and case control study has more risk as compared to case control studies had more risk as compared to cohort studies, and studies before 1990 has more risk. And coming to the specific item, like pan tobacco has maximum risk 7.18, and which is the maximum risk which compete at the second place. Maximum risk was with gutka, in which we analyzed 4 studies found with the risk of gutka, and they have given us a risk estimate of 8.6. And second place is the pan tobacco. And similarly, the manpuri tobacco also has higher risk, 3.2. And here you can see that nasal snuff or dipping product has 1.2 risk only. So the maximum risk you can see in gutka product. So here we can also the substance that are use a mixture of various things, like gutka has a mixture of tobacco and various other products. They are having more risk as compared to a single product, like and this nasal snuff and dipping product has lesser risk. Similarly, the age adjusted risk was more in non adjusted as compared to age adjusted. So here we if we compare our study with other existing literature that were the systematic reviews that were conducted before our study. So there were though there were systematic reviews, but they have some deficiency or other, like risk study by Zidigi et al. They have what they have done, and they have not, their study was not inclusive of every study, and there were few studies that were not there. And apart from that, along with oral, they have taken nasopharyngeal studies also included in that. So they were not specific to the oral, where we have taken into consideration only those studies that were pertaining to oral cancer. And apart, there are very few studies at global level, and those studies also have not done the specific itemized, like smokeless tobacco itemized analysis. They have not done, where we have done that. And we have
Sorry
done.
to interrupt you, Dr. Smita. Sorry to interrupt you, ma'am, but you have overshooted the time limit.
Okay.
I request you to kindly finish it.
Yeah, so it's like each country should see, and they have to, like in India we have ban on gutka and things like that. So there should be specific need to develop such type of policy decision for a specific product. Thank you so much.
Thank you, Dr. Smita. I invite Professor Subrata Vaidya sir to please guide her in the study.
Actually, she has exceeded the time. This is she should be within this time, but within this short time she cannot present that systematic review like this. She tried it, but she could not show us this forest plots and that which she has shown for the from the WHO study, but from her study she could not show us the forest plot. And regarding
Sorry, excuse me, sir. This is from our study. This forest plot is from our study only.
oh, achha,
We have
so
not
sorry.
included any other person's material, because our study is such a big study, and then we have used many forest plots in that. So one of the forest plot of our own study we have shown, and not the WHO, sir. Thank you, sir.
Okay. So another thing, that heterogeneity test also you have done, na?
Yes, sir. I square we have used, and a lot of heterogeneity were there, because this is a different geographical region, and the variation was more.
So what test you have done for that heterogeneity?
This is a automatic Revman 3.5. There is automatically I square value. The output computer output itself give. So we have not we have taken output from there I square value, and that I have shown in
okay.
that.
And in calculation you have taken the random effect model, na?
Yes, sir.
Okay. So that is from my side. Okay. Thank
Yes,
you.
we have taken.
Okay.
Thank you, sir. Thank you for your guidance. Dr. Gerard Singh Hanspal, sir, now I would invite you to please guide her in the study.
Dr. Smita, basically, I just wanted to know that your study, you wanted to show what in your study?
Sir, my main objective was to see the effect association of smokeless tobacco use with the oral cancer at global level. That was one objective. And apart from that, there were various. I have seen the difference between male female also, in which female was found with higher risk. at different global level, what we have found that Eastern Mediterranean, Southeast Asian countries have more risk as compared to European countries. Maybe at European countries, the Europe and Americas, they are usually basically using the product, and those are used after a lot of curing, and they use various processing methods that reduces the carcinogenicity of the tobacco products. So that is the reason that they are using such type of a product, and that those processing actually reduces the carcinogenicity. So that's why the crude product that we are using over here in Southeast Asian countries and Eastern Mediterranean, these products are in crude form, so they are more carcinogenic as compared to that. So that was one. Other thing is like the specifically we have individual itemized product risk. We also estimated, pooled the values of individual, like various studies on pan, tobacco, gutka. So in my table I have shown how many studies for which item. So because we have done various subgroup analysis also at the same time. So all these things, various subgroup analysis, what is the overall individual risk of various smokeless tobacco products at global levels.
India is already, I think, leading in this smokeless tobacco.
Yes, sir. Yes, sir.
Leading, and comparing with the whole of the world or global, I think it is not that much will give you quality, rather than to those comparing with those continents and those countries where they are using in large extent. If you compare with Europe and all these things, there the quality and the technology is such that will not be like you will not be in the same cohort, I can say. So comparing the whole world with India, it little bit diffuses the study. Like for example, I want to ask do some study in urban slum. I'll be looking for those countries where urban slums are there. Okay, or in those countries or those continents where the number of urban slums are there, so that I can my quality of comparison will be good. So taking the whole world in that will little bit diffuses the study.
So, sir, thank you for your suggestion. It's these comparative, that was one aspect. That were done earlier also. Earlier also, systematic reviews were available on that, but there were some flaws. Like the study by Siddiqui et al., what they have done, they have included oropharyngeal also along with the oral. So that was one flaw. Second, they have left out few studies. So that was second clause. Third thing is like they have not considered study from few studies from important studies from Eastern Mediterranean region. So that was another part. So there were flaws in earlier reviews. So that was one thing. Another thing is like the smokeless tobacco type specific analysis that we have done has never done before.
And moreover,
So because like individual itemized product pooling of the data that we have done is never done before. And though male and female risk analysis was done earlier also, but
main
in
thing,
subgroup in
one minute.
different continents or like India specific, but not at global level.
Main thing is that I wanted that in this type of study you should be little bit more focusing or more localized, rather than your study is very much more of a global thing, and that
Yeah.
what I as an experienced person will say, that the remedies or the solutions in your conclusion, it should be there, which is not. Your conclusion is simply saying कि ये problem है, but the thing is that in India ये problem बहुत देर से है, पहले से चल रहा है. We should be focusing more on now solutions. There are many studies in India has already been like when I was in PG some 20 years back. Then also at that time also the studies were there, Sachin. But now we should be looking for the solutions for this thing. Like specific initiative should be taken, this should be done, this be done. No, this is little bit quite diffuse thing. ये करना चाहिए, करना चाहिए. The thing is that how we can do, especially like in India, I say that in some southern part of Gujarat, the smokeless tobacco is more. Now what should be I'll be doing at the ground level, rather than, of course, this study is definitely will matter, but in country like India, now we should, think about the solutions at the 21st century. We should be doing.
Yes. Yes.
Solving the problems practically.
Yeah.
That is what my approach is always like that. I
Yeah.
take my community medicine very practically.
Oh.
That is what I was seeing in the study.
Thank you, sir, for your guidance. I invite Dr. Sonika Sangra if she has any questions.
Dr. Smith.
Yes, madam.
Smita.
Yes, madam.
Future recommendations. What are your recommendations with respect of India?
Ma'am, your voice is breaking. I could not hear. Ma'am, your voice is not clear, madam.
Now audible?
Yes, better, little bit.
What are your future recommendations?
Can anyone please, Shreya, Dr. Shreya, if you can repeat what I'm not able to, because voice is breaking.
Sorry, Dr. Sonika Sangra, ma'am, but your voice is actually not clear to any one of us. Maybe there is some network problem.
Oh.
Ma'am, could you please repeat your question?
Okay, no problem. What my question is, what are your future recommendations? Future recommendations.
Future recommendations. Actually, we are our institute. This is a part of a global knowledge hub, and our institute is working in field of smokeless tobacco. Like future recommendation, like more and more weightage is given to the smoking product, but the focus is somewhere deviating from the smokeless tobacco product. So future recommendation is specific steps should be taken towards smokeless tobacco products in addition to whatever is going on, because there are various in India there is a culture of like giving at some places giving pan, giving some different zarda and all that, those things they if they don't give it to someone, the guest, then they think that this is not good and they have not like welcomed us properly and things like that. So this type of awareness should also be created among the populations, like these things having this much of problem, and these things lead to, because this was just a part, like oral cancer, like our institute also working on different other this project, the what we have done this work is apart from that, different other carcinogenic effect on different site of cancer is also going on. So making public also aware about these such products is a future recommendation, like rather than making whole of the focus towards smoking, we should look towards smokeless also.
Okay, thank you.
Thank you, Dr. Smita Asthana. I would request you to kindly stop sharing your screen. I invite Dr. Rita Devi to kindly share her screen since we are lagging in time. So I request all the participants to please adhere to the time limit. Dr. Rita Devi. Your screen is visible. You can start with your presentation.
Slideshow. Actually, slideshow is a problem.
It's the fourth option. Ma'am, yes, ma'am, next to, ma'am, next. Ma'am, more next option. The option you chose, na? Next to this, and ma'am, just before the minus sign.
Actually, screen.
Ma'am, it's visible. You can start now.
Okay, a very good morning to all, and chairpersons, respective chairpersons. The topic I am going to present is effectiveness of an educational approach on foot care, knowledge and practices among diabetics. So as foot care is often neglected both by the caregivers and the diabetic patients, so the objective for the study was to assess the effectiveness of an educational approach in the community setting on the knowledge and practices regarding foot care in East Delhi. And the methodology was, the study design was quasi-experimental with the control group, and pre-test and post-test was done in both the groups, and it was a community-based interventional study. And it was done in the residential colony in East Delhi. Study subjects were type 2 diabetic patients between the age group of 20 to 80 years, and the sample size was calculated based on the study by Malathi R. et al., in which the increase in the knowledge from 50% in the pre-test to about 65%, there will be increase in knowledge, and with 80% power and 10% attrition rate. And after 3 months of intervention, based on these parameters, the sample size was calculated, and after sampling, we identified 340 type 2 diabetic mellitus patients by house-to-house visit among 1,400 households, which was based on the available medical records of the patients, as these patients were listed and numbered. And then they were divided into 4 groups of 85 patients in each group. As per these, the number 1 to 85 in group 1, then 2, 3, and 4. And the 2 groups were selected by lottery method for the 1 group for the intervention and 1 group for the control. Then informed written consents were taken from the patients, and the baseline pre-test knowledge was assessed using a semi-structured interview schedule, and then intervention by PPT with demonstration of the procedure, which was pre-recorded on the foot care practices, and it was validated and pilot tested, reliability was established, and then a Hindi version, it was translated and then retranslation into English, so that to establish language reliability. And then the results were analyzed based on the findings for the knowledge score, and the 1 for each correct answer was the score. And for practices, it was used the observation checklist to assess their practices on the foot care practices. Then statistical tests used were qualitative, for the qualitative variable chi-square test, McNamara test, pair t-test for the scores, and the p-value of less than 0.05% was considered significant, and the approval was sought by the doctoral committee of School of Health Sciences, IGNOU. And the socio-demographic characteristic of the studies subject showed that majority of the study subjects were in the like intervention group, and the post control group were between 50 to 59 years of age were the majority, and gender wise the male were more than the females, and literacy status wise the graduate and above were more than the other groups, and it was similar in both the groups as PPT as well as control before the intervention. Then as per the occupation wise, the study subjects were more of in the household work, and the retired were also in more in number, that is 15 or 21, and they were similar across in both the groups before the intervention. According to family size, family type, more were in the nuclear family in both the groups. Family size, according to family size, again 1 to 4 number of family members in both the groups, it was similar. And as per the religion, majority were were Hindus, followed by Muslims, and then Christians, then Jains were also there. And as per the economic status of these study subjects, they were also similar in both the groups before the intervention. And if we see the perceived awareness about the that diabetes affect feet among the study groups, it was found that in the before the intervention, it was similar knowledge level in both the groups, but after the intervention, and it was assessed that the perceived knowledge regarding the that it affect the feet, it has increased in the PPT group rather than, but in the control group, the knowledge remains the same. This shows that the intervention was effective in increasing their knowledge regarding this aspect. And the other diagram, which shows that the foot examination among the study group, that it is important to examine feet during when they are diabetic. So if we see the this slide, the PPT group had 100% increase in their knowledge regarding foot examination as compared to the control group, which has just it was not significant. Then the knowledge score, actually 3 parameters of the knowledge scores were assessed: their knowledge on the foot inspection or examination, how to take care of feet, and the what are the symptoms of feet if get affected. So these were the things. At the mean score with standard deviation in the pre-test knowledge, it was in the PPT group as well as in the control group before the intervention was similar, it was not significant. And after the intervention, the post-test score was significant at p-value of 0.001. That shows that there was a significant improvement in the knowledge of the foot care, about foot care in the post-intervention group than the control group, where there was not significant improvement. Same way with the foot care practices, which was assessed using the observation checklist before the intervention. And
time.
Okay, so I conclude that the intervention was effective in increasing the knowledge as well as practices among the intervention group rather than in the control group. Thank you, sir.
Thank you, Dr. Rita ma'am. I invite Dr. Subrata Bedya sir to please guide.
Actually, the study which she has done, that is a very good study. And different occasion we have seen the health education improves our quality care seeking behavior, and this is very much pertinent related to the now with the diabetes food care and all. So
Yes.
I think this study we can accept one of the good studies. He has done everything: sample size calculation, there's a good research question, then sampling that that can be helpful to generalize also. So I
Yes,
think that's
sir.
a good study, well planned study. Thank you. from my side.
And patients were also appreciating that they were not at all aware that something to do with their feet. So,
Yes, yes.
and
Actually,
they expressed that doctor never asked them about their
the
feet.
the
So
the
I
problem in
told them
our
that you are
country.
the doctor for your own feet. So that was really at one-to-one basis I had done. So it was.
Yeah, actually, problem is that diabetic patient education.
Yes, sir.
People are coming to the doctor, they are giving medicine, insulin
Yeah.
injection, and just dietary advice. But the
Yes, sir.
food care, then other risk factor, then they
Yeah.
very less time for us to explain there. So there should be certain
Excellent.
strategic plan for
Yes.
NCD, the
Yeah.
education, the in fact these all the whatever IEC activity, I
Yeah.
think that won't suffice much. Okay,
Yes.
so that is good. The one-to-one interaction or group
Yes, sir.
teaching or group counseling that helps.
Yes.
Okay,
Yes,
thank
sir.
you very much from my side.
Thank you so much, sir.
Thank you, sir. I would like to invite Dr. Jara Singh Hanspal, sir, to kindly enlighten with your guidance.
Dr. Nidhi, how you have selected your 1400 households?
Sir, I had baseline structured interview schedule in the first phase. It was done in the two phases. So in the baseline, door-to-door survey was done to find out whether any diabetic is there in the family. And then self-reported cases were taken, and I asked them to show their medical records, those who were on the
But
medications.
how,
So,
one minute, please.
yes.
My question is how 1400 households? How you have
Sir,
done? I am not asking you. How you have selected 1400 households?
Sir, the setting was selected as I am familiar to this setting, because in Delhi it is not easy to go house to door. So I selected my own area where I am residing, and there also I had to face lot of problem, because the people does not come out because they are not familiar with this kind of that somebody will come to their house for door home visit and all. And I had to face a lot of reactions from these household. So I selected 1400. That means these total 1400 houses of this locality there. This is the actually out of 21 blocks, this is the largest block where I am residing. So I took this block and another block. So two J&K and I pocket were selected, and these total houses were there, in which I identified these diabetics.
Okay. Patient selection, how you have made your patient selection like?
Sir, initially 461 patients were listed. Out of that, there was inclusion criteria. Based on the inclusion criteria as well as the sample size calculation.
Patient selection, number of patient selection I am not saying. Patient selection.
Sir, those who were willing to participate, as well as those who gave written informed consent, as well as those who were
what was
not having, because it is a self-care practice. It is a self-care practice. We cannot take those patients who are bedridden, those who cannot do their care themselves.
Madam, please understand my question. You should have found some characteristic of the patient. Then
yes,
you
sir.
those patients.
Yeah. So I selected that those who have self-care ability, those will be taken, and those.
What was more important than that for the selection? How you have selected those patients? Okay, I'll select this patient.
So they should be willing to participate first of all.
You say who is first diabetic? That is more
important. Yeah. After, yeah.
And all were diabetic.
They were on medication. Those who were on medication, they were diagnosed cases, and they were willing to participate, and they are able to take self-care of themselves. Rather than if they are dependent, they won't be able to do their food practices themselves also.
Okay. And in that diabetes, what do you think that more important for this food care? Have you found out of maybe you can do it further?
Yeah. Yes, sir.
What is more important food care for the food care practice in diabetics who have uncontrolled diabetes, which is very common in India?
Yes, sir.
So you would have selected to make the things more, like where you can find the real effect, you can find those which is easily you can find it out in Indian scenario, who have uncontrolled diabetes.
Yes, sir.
Person who
Some
has,
of them were there.
this is there. What you are giving is a awareness.
Yeah.
Awareness.
Yes, sir.
Maybe that
Yes, sir.
person's diabetes because you have taken 20 year also. Those
Yeah,
person who is very well controlled diabetic,
Yeah.
very less chance that he'll have any food problem. Okay,
Sir.
this is just a
Yes.
basic data.
Yes.
Now it should be that who have got uncontrolled, because that is a very big risk factor for the
Yes, sir.
uncontrolled
Yes, sir.
diabetes in India.
Yes,
So
sir.
you
Yes,
can
sir.
make a study where all their participants is uncontrolled diabetes.
Yes, sir. Yes,
Then
sir.
it will directly affect
Yeah,
your.
exactly. Yes, sir. Thank you so much, sir. Yes. This is the
Thank you,
need
sir.
of the hour. Thank you, sir.
Thank you, sir. I invite Dr. Sonika Sangra if she has any questions. Thank you, ma'am. Ma'am, now I would invite the last but not the least, our last presenter, Dr. Nidhi Prasad, registration number 106, to kindly share her screen. Ma'am, your screen is visible to us. Kindly unmute and present your slides.
Good morning, everyone. I'm Dr. Nidhi, and today I'll present the topic like prevalence and correlates of nicotine dependence among the construction site workers at Patna. So, as we all know, that smokeless tobacco, basically it deals with the smokeless tobacco, because smokeless tobacco consumption overall is a major health problem, and most of the deaths, like 4.9 million deaths, are due to the tobacco consumption. And I have taken smokeless tobacco because it is banned in Bihar from 2015, the gutka, pan masala and zarda. So in the college premises, I could see the construction site workers consuming smokeless tobacco. So I thought to include them in my study. So with the objective to assess the prevalence of nicotine dependence, and to study the correlates of nicotine dependence among the construction site workers. So the methodology was cross-sectional, and the study area, the college and the hospital premises, because the construction work is going on here, and the construction workers, whoever are deployed here, will be included, will be the part of the study, and the study duration was 1 month. So the workers who were 18 years and above and working in the campus of IGMS were included, and the workers who did not give consent were excluded from the study. For nicotine dependence, Carl Fagerstrom's nicotine dependence questionnaire for smokeless tobacco was used. So we could find that the mean age of the construction site workers who were working the campus was approximately 30 years, ranging from 18 to 60 years. And among the workers, majority, like 68.25% of the workers were using smokeless tobacco, and among them 64 were having moderate to severe dependence. This dependence was taken like the score, whoever were having a score of less than 3 or equal to 3 was kept in mild dependence, and the score having whoever having a score from 4 to 10 was kept in moderate to severe dependence. It is how the scoring is done in the same exact manner we had taken. So Kenny was used mostly in most of the proportion, like 88% used Kenny, followed by Gutka, though Gutka is banned, but it was used by 12%. Now, the average nicotine dependence score was 4. So on analysis we could see the among the socio-demographic characteristic. Mostly these workers belong to 21 to uh, 30 or 35 years of age. Mostly the workers were among this age, and we could see easily, like uh, the migrants were having a greater tendency to use, like the tobacco use was associated with their being migrant and also with the education. Uh, so on entering all the variables together to see the associated factors, we could see like mm, the being migrant and education and the marital status were significantly associated with the tobacco use, smokeless tobacco use. And this is the characteristic of the persons who were having dependence, mild dependence compared with the moderate to severe dependence. So we could see the marital status was associated with the dependence. And on entering all the factors, we could see like only the marital status is found to be significant with the tobacco dependence. So thank you.
Thank you, Dr. Nidhi. I invite Professor Subrata Vaidya, sir, to enlighten with guidance.
Hello.
Yes, sir.
Yeah, yeah. This is study done, but thing is that just simple statistics, something has been done. But how you have done the scoring system more than four
The
or less than
scoring
three? Whether
system is
the very
the Carl Fagerstrom scoring system for
बस इन
smokeless
तीनों के
tobacco.
नाम और इनकी वो डेजिग्नेशन फ्लायर में से देख के
okay,
बस इतना बता
okay, that one you
किसी
have
को नहीं
done,
है
na?
Yes, sir.
सबके
Yeah,
आए हैं ना
So this
but
was planned because initially when I came in the campus, I saw some
अरे वो
people
फ्लायर
were using smokeless
टीवी में से देख
tobacco,
लिया ना
and
फ्लायर में
as we
जाके
know, like these
फ्लायर नहीं
groups
बनाना
are having a great tendency to use. So I was not knowing what is the
अब
prevalence
कुछ
or
नहीं
how
हो
many are
सकता
using. So just to find out that how many persons in this group, because these groups, as we assume, are
बोल देना
using more smokeless tobacco.
चेयरपर्सन
Because in previously also I had done certain studies, so I found out that work or physical labor
person
or such kind of works
इनका नाम क्या है
or persons doing such a kind of works are more prone
अरविंद
to use
रक्षण
smokeless
अरे
tobacco.
से पूछ लो फटाफट
So it
I
was just a
welcome
baseline study
sir
to
and ma'am.
see the factors that are
I
associated. So
invite
I could build
I
up
welcome
on
all the
another
presenters ऐसे
and
करके कर
to
दो
find out other factors also
ठीक है
that may be
so
associated.
how? Yeah, yeah. How you will be utilizing the what result you got it from here?
Sir, I had
Whatever
asked
you.
them reasons also. So I was
Hmm.
planning to use this, like the persons who are dependent on nicotine. I was planning to do a qualitative study to find out the other reasons, because lot many studies have been done to find out the factors. But when we take these factors and we plan an intervention, I think like it is not. There are certain other factors also, and now it's the need of the hour that certain other factors should also be looked into, because it is an immense problem and the burden is yet high, like smokeless, because of the ban of cigarettes and beeries in the workplace. People tend to use smokeless tobacco because they generally escape from the supervisors. They take it in the break hours. There's a tendency to escape. So we cannot do with that until and unless we know the reason exactly, like how can they leave this habit.
Okay, okay, okay. Thank you very much from my side.
Thank you, sir.
thank you sir I invite Dr. Jera Singh Hanspal sir to provide his guidance
Dr. Nidhi,
Good morning, sir.
basically, your study, you have
Yes,
done
sir.
a study very conveniently.
Yes, sir.
You are a PG student?
No, sir. Actually, I'm a faculty over here, but the problem was that when I came to know the sampling frame, there were 300 workers, and each worker would change on each day. Like 300, they were on the daily wages, so I could not find the same worker the next day. So I decided, or I planned to include five per day, and according to that, I plan my sample size.
This was the factor, I know.
Yes, sir.
I am saying you did this study too conveniently for finding your samples, I think. Rather, there was no sample size also, I think.
The sample size was like 172 people when included, and minimum I had kept a sample of 100.
That is what I'm saying. This is
Yes, sir.
not. That is why
Yes.
I'm surprised as a faculty also.
No, sir, because there were constraints like the supervisors would not allow them to come for interview even after
It
the
is not
study was
their fault.
over.
See, it is not their fault. It is your fault. Right? For selection of the, not sample size, for selection of the people for the study. You have already, you knew all these factors, till you have selected them. That is the problem. You could have taken some area or something where you can, now what you will do, you have studied, you have found out the data, that's all now. Whom you will be telling them about all this, what should be improved?
Sir, I had called them after taking
But they are
this.
changing now. Some will go to the village, some will be going to their own native. Now, you have taken the study where, it is highly motile or highly, changing the number of people they are changing, day by day.
Yes,
Daily.
sir. Yes, sir.
So how your quality of the study will be taken? Why you have done this study, for the presentation?
No, sir, not for the
Not for the
presentation.
presentation, no,
So,
obviously.
sir, whenever I was going in the campus, I would see like the
No,
workers.
no, no. This is not a reason. I have already told this reason to the sir, but this is not the reason. You have seen, so you are doing. Maybe you can see. That is what I am always saying, that your study should matter, na. What you will be doing after this study? What
So,
you will
sir,
do? Suppose you
just I
have.
wanted to ask, like in these group or these groups, whoever is doing physical work or labor, they have a unique reason, like why they are using
That
tobacco,
is
and
their addict,
mostly.
that is a very black and white thing, and everybody knows, they are already addicted to that. वो आप पूछोगे बोलेगा नहीं हमसे काम नहीं होता अगर हम ये लेते नहीं है तो. I'll tell you the reason, major reason. They will say this only. You just
Sir,
ask them, you
Sir,
will
I had
get.
done another study also in the house keeping staffs and the nursing orderlies, and they had a very unique reason, like the kind of work they do, the kind of smell that is persisting there, or the work that they assume that's very dirty. And with that, though that false assumption they had that the tobacco would relieve them of that, or the bad smell would cut the bad smell and or something like that. So I thought that I would come with any unique reason, like in this
You
group
have
also.
taken. That is what I am saying. Na? Your selection is housekeeping. Housekeeping are there who are already working there. Na?
No, no, sir, it's another study. Like I was
No,
telling, like I wanted to just study in
I am
different
just
groups. Like,
talking.
what is the reason?
I am just saying that their selection is something permanent type of thing. Na? That
Yes,
house
sir.
working are there
Yes,
who
sir.
are already working.
Yes, sir.
Suppose you do, where your quality will lie. Your quality will lie. You do the study. You find out the prevalence about some X population. Then you tell them something how they will improve. That
So
is
for
the
that,
main part.
so
Na?
for that, I had called them. I had invited them, and I had given a health talk regarding all those factors I had found out. I have slides for that,
To
and I had
whom?
given a health talk for
Nothing.
to
To
those construction site workers.
But they have
I
already now changed. You won't be finding all those people who have you have done study.
not exactly the same, but
That is the thing.
among the people, because it was difficult to conduct each and
It's
every day, so I
very.
called most of the them in my department, and I conducted a health talk, at least
Let
to
me
do
tell you.
something than nothing.
No. That thing should not be there. Na? We are not running somewhere. So whatever study you do, it should be of practical use to those population whom you have done study. Otherwise, if the people will go, the main purpose is lost. So you
Okay.
have to find those population, or you have to find out. Maybe you can do in some construction site where from the supervisor will come to know if these people, for example, they are from Bihar and Eastern UP, and they will be staying here for 1 month. All the people. Then only you can say for this population also I can give you suggestion.
Okay, sir.
You just first find it out from the supervisor. ये सब रहेंगे क्या? हाँ जी 1 महीने तो रहेंगे ये लोग, कहीं नहीं जाएंगे.
Okay,
ताकि आप स्टडी करो और वो स्टडी को आप उसका उनको यूज भी तो होना, कुछ उनको सुधारना
yes
भी
sir.
तो है ना.
Yes sir,
आप
definitely.
ये समझिए, एज अ पब्लिक हेल्थ पर्सन, एज अ कम्युनिटी मेडिसिन पर्सन, हमें सुधारना है सोसाइटी को हेल्थ पॉइंट ऑफ व्यू. हमारे दिमाग में टारगेट यही होना चाहिए. ये क्यों कर रहे हैं हम लोग? ये इसलिए कर रहे हैं कि हम इनको कुछ भला हो जाए इनका हेल्थ का. है ना, जैसे आपने हाउसकीपिंग वाले का करेंगे तो आपका वो अच्छा हो जाएगा, आप वापस उनको जाएंगे बताएंगे नहीं ऐसा नहीं है, that will of real use. Okay, thank you.
Thank you, sir.
Thank you, sir. I would invite Dr. Sonika Sangra ma'am if she has any questions for our presenter, Dr. Nidhi Prasad. Thank you, Dr. Nidhi, for your presentation.
Thanks a lot.
With this last presentation, we are done with today's session. I invite Professor Subrata Vaidya, sir.
Yes.
Sir, please conclude the session with us. Kindly share your kind words with us.
Actually, the presentation wise, some studies are very good, and some I think there is a scope for improvement. And this is a total thing is the learning things. So I think as we are discussing the learning, they should talk with their mentors and try to design the proper study. And when they are trying to do some study in the public health, so public health study there should be certain scientific basis, and that can be utilized for benefit of the people, and if possible the translation of the knowledge in the for the community, so that help us when we are doing some study. It should not be with the just for the study itself, but always we have to look for the translation and implementation research. Whatever we are doing may be small thing, but that can be implemented or that can be replicated any other place. So that's a message from my side. Thank you
Thank you,
very
sir.
much. Okay, I will leave the session. Okay.
Sure, sir. Thank you, sir. Thank you for joining us, sir. I invite Dr. Jairaj Singhpal, sir, Hanspal, sir, to please share your kind words with us.
Basically, right from my PG time, because I took community medicine by my choice, getting most of the clinical subjects. My matter is always such, and till date also, that whatever we are doing in the community, because there is a big scope and there is a big need also in a country like India and today also, that we have to make the people aware of the health problems, and which easily minimize the load on the hospitals, which can easily minimize load without any much trouble and much initiative. But only the thing is that uh, we are the people, or the youngster which I am seeing here, they are the people whom their heads or their professors or their seniors should guide them accordingly, that for what purpose they have been here, or they are doing their PG in community medicine, or when they become a community medicine specialist, what should be their aim? Like always, I used to tell, I've been a professor and head in for 9 years, though though presently in a government there was no additional post, so I am professor associate now. So there I used to always tell my PG students that for what purpose you have taken, you should be very clear. So my all studies, what I am saying, I used to follow myself also when I was a student, and now also I follow the same thing, that whatever the thing they are doing, they should have the final aim. Why I am doing this study, for what purpose, how it will benefit the population or the community. That thing should be very much clear. That is what I was seeing. That is what was lacking in today's study. Because
Yes, sir.
whenever I ask the practical aspects of the thing, they were little bit here looking here and there. Okay, I see. And everybody was just included. मेरे रिजल्ट में इतना आया, चलो भाई खत्म. So that was there. In one of the, I was invited as an examiner in one of the AIMS as MPH. So there also, whenever I asked their practical part, the students were, not able to answer that why you're doing. Passing the thing is a different. Practically applying in life should be of more important. Thank you.
Thank you so much, sir. So we end this session with your permission, sir. Thank you for your much valuable time and guidance. And I appreciate all the presenters, faculties, and dignitaries who have joined us here and have shared their great intellectual minds, ideas, and researches with us. Great thanks to you all. Now I would hand over the session to Ms. Nitesh, who will be taking the next session. Thank you all.
The
The
oral
oral
session
session
7
7
ends
ends
here.
here.
Thank you so much, ma'am.
Thank you.
Good morning, respected chairpersons, eminent speakers, and delegates. A very warm welcome to all of you from the team Eficon 2020. Now we start our poster session, non-communicable diseases. We have eminent personalities as the chairperson, Dr. Neelam Kumar, professor, who have done his MBBS from Jawaharlal Nehru, Lal Nehru Medical College and MD from the same institute. And he had the work experience as a professor, associate professor in many institutes. Another chairperson is Dr. Rajiv Arvind Dakshan, who have the teaching experience of more than 25 years, and he have served in Kasturba Medical College, Mangalore, and many other places. He have the research experience. He have worked in various clinical research projects and have more than 70 publications in reputed national, international journals. And his area of interest are clinical research, application of IT in medicine and e-learning. And next chairperson is Dr. Bhushan Kamble, who have completed his MBBS from Sheikh GS Medical College, Mumbai, and MD from the VMMC and Safdarjung Hospital, Delhi. He is currently working as an assistant professor in Institute of Medical Science, BHU, Varanasi. And I, Nitesh, is the coordinating member for today's session. तो कौन से करनी है? Now I request our first speaker, Dr. Sunil Kumar Singh. Please come and present your poster on the title Prevalence of Obesity and Associated Factors Among School-Going Adolescent Boy in Rural Health, Delhi.
Hello.
Hello, Dr. Sunil Kumar, are you there?
And can we move on to the next presenter? Time is running short.
Dr. Runalika Roy, are you there? If you are there, please present your screen.
Yes. Am I audible?
Yes, ma'am.
Yes.
You may proceed, ma'am.
Is my screen visible?
Excuse me, what is your ID, please?
My registration number is 134.
134. Thank you.
Is my screen visible, sir?
Yes. Okay. Okay, you can start.
Ma'am, it's a joint request. Please adhere to the time. Your time limit is 5 minutes.
Okay, thank you.
Good morning, one and all. I'm Dr. Runalika Roy from Department of Epidemiology, NIMHANS. The title of my study is Overweight Among Employees in a Leading Automobile Industry, Prevalence and Associative Factors. So coming to the introduction, so as we know that overweight is a major risk factors for the NCDs, and it constitutes a serious public health challenge that undermines social and economic development throughout the world. And prevalence of overweight among men as per the NFHS 4 is 18.9%. And also we know that in worldwide prevalence of overweight and obesity have become double since 1980, and it affecting most of the people and consecutive serious risk factor for the NCDs. But however, in India, the workers form also a subset of the population, and they are likely to be impacted by ongoing macro level social and epidemiological transitions that is happening. So, but at the industry level, the data are very much limited. So, based on in that direction, we have done this record analysis study with the objectives for the prevalence to determine the prevalence of overweight among the employees, and also to find the specific prevalence by their age, region, that is from where they belong, and their type of work. And also if there is any association of overweight with the type of work, region, and age group. So the study setting is the automobile industry in Karnataka, and it is a record analysis study. So our data source for the study was the annual medical examination of the data from 2010 to 2018, and our study was conducted during March to June 2019. For this study, we have for the overweight measurements, we have used the WHO BMI criteria, and and we have collected the data from the organization's occupational health department, their HME's data with a unique ID. We have merged the data and prepared the data for the analysis. For the region wise, like we have divided the region as with the coastal Karnataka, Malnad Karnataka, North Karnataka, South Karnataka, and other states. And we have, as per the type of work, we have divided the employees in the production and non-production department based on their type of work, like kind of paint production, internal logistics control department. So these the employees who are working in the assembly line production, so they are constitutes the production department, and those who are working mainly in the office work, so they are constitutes the mainly non-production department. And the age group we have divided like 18 to 24 years, 25 to 29 years, 30 to 34 years, and 35 to 39 years, and 40 years and above. Like this, we have made the age categories. So analysis for that, we have seen the overweight prevalence of overweight, and also we have done the specific prevalence rates like with the as I have mentioned, like the age, type of work, and the region. So for that, we have used the chi-square test to see the differences, and chi-square trends, so the year-wise trend we have observed. And for the multi-grade analysis, which we have done was the logistic regression only for the year for 2018, and P less than 0.5 was considered to be significant. So coming to the results, like we have seen that the prevalence of overweight ranged from 25.4 to 33.3% between the year 2010 to 2018. And see, if we can see the graph, so we can see how the trend of overweight has been increased in 2018, and ranged from 25.4 to 33.3. And then coming to that, there was a significant increase in the trend also, coming to the specific prevalence rate. So it came from the increased overweight prevalence was seen in the non-production department and the South Karnataka and the 35 to 39 years age group. In this group also, we have seen that there is the increased prevalence of overweight was found. So this constitutes the trend in the different regions. So we can see that in the South Karnataka, we can see the trend was there. So in all the regions, the trend of overweight was consistent. Now coming to the risk of overweight, we have also seen that production department has 19.1% less than race risk, and comparative to the other states, and other states has also 42.8% high risk, and 0.5 years people have 56.4% less risk of being overweight. So coming to the conclusion and recommendations, like we have seen increased prevalence of overweight among these employees, And for that, we recommended screening programs like weight monitoring to prevent to halt the progress of NCDs, and also like workplace health promotion and risk stratification and risk-based intervention is needed for specifically for this high-risk group. Thank you.
Thank you so much, ma'am. Now I would like to invite our persons to ask the questions.
Hello. Hello. Hello.
Hello, yes, sir.
Yes, sir.
Am I audible?
Yes, sir. You are
Yes,
very clear.
What thing trigger you to take up this study? How do you become interested in this type of study? Hello.
Yes, sir.
What trigger you to take up this study? How did you become interested in this study? What is the rationale of your study?
Sir, actually, this employees in the industrial employees, because they form a subset of the general population. So we wanted to see it is based on record analysis. So how was the trend of overweight became in 2010 to 2018? So like that, we divided the employees in the different categories. So that is based on those categories, we have also seen the specific prevalence for the overweight prevalence based on the variables. That is the type of work, the regions from where they belong, and their age categories.
May I ask a question?
Yes, sir.
Yes, sir. Sure, sir.
Okay, nice presentation, Runalika ji. My question is like you have presented the study as record analysis, and that looks like a cross-sectional study. And the findings are group-wise, but your analysis is logistic regression. So how did you compromise between individual data analysis and the group-wise conclusion?
Sir, actually, it is it is not a cross-sectional study. Only the 2018, because we have found the highest prevalence. So only that portion we have just done for the to see the risk of being overweight. So only that portion, but the other components are all the record analysis from 2010 to 2018 we have seen. For the graphs, I was not able to put all the graphs. Because it has like for mainly like for the type of work region, there was one more graph of the age categories. So it was mainly, sir, from the 2010 to 2018 that record analysis we have done, and the chi-square for trend that we have used to see the changes based on the years. Only 2018 we have got only that portion of the data we have used to find the risk of overweight. So only for that portion, sir, not the other.
Okay, how did you find the trend?
The trend we have found, sir, increase in the overweight prevalence across the years. And so what we have seen that in between, there was actually, and this study was a part of an ongoing programmatic intervention. So it helped us to see the trend, like how it was earlier and how it is happening now.
But then it will be paralleling the increase in overweight in the population also
yes, sir.
Generally, yeah.
Yes, generally it is there. So, but since as we know that this workers also form the part of a general population, subset of a general population.
Yeah,
but because it is an industrial study, yeah, it has the limitations of the study that the occupational health studies have. So,
and on a lighter note,
also.
On a lighter note, how did you find South Karnataka to be, on the higher side?
Yeah, so actually that is what we felt. We interviewed the occupational health medical officer.
Now, do you think their education level and socioeconomic status is better than the other parts of the state?
So what I discussed with my mentor, so it was like mostly South Karnataka people, they are eating more rice eater there mostly, and as I have found out that from the North Karnataka they are only millets. The diets are only millets.
Thank you.
So
Thank you.
maybe some dietary and cultural practice can be different, and for that further studies regarding this aspect has to be explored.
Thank you. Thank you. Thank you. All the best.
Thank you, sir.
Thank you so much, ma'am. Now I request you to please stop sharing your screen, and I would like to request to invite Dr. Sunil Kumar Singh to share your screen, please.
उनका नंबर क्या है? Registration ID.
Dr. Sunil Kumar, can you hear us?
हाँ करना सर. कहाँ से
Sir,
करूँ?
please share your screen.
क्या मतलब बाजारी है ओके?
I guess some technical glitch.
Maybe there are some network issue.
Yeah.
So I request our next speaker, Dr. Ajit. Please share your screen.
Hello. Hello. What is
Am
the
I audible,
ID
sir?
of this ID?
Am I audible, sir?
Pardon me?
Yes, sir, you are well audible, sir.
What is the ID of presenter?
Sir, my ID is 114, sir.
114. Thank you. Okay, go ahead.
Go ahead, sir.
Okay. Good morning, all. This is myself, Dr. Ajit Devarma, and I am currently doing my MPH at NIMANS. And my study title is Epidemiology and Burden of Stroke in India, a systematic analysis of global burden of disease study 2017. As we know, stroke is one of the leading causes of mortality and dialysis all over the world. And India at around
Pardon for
11.5.
interruption. Please pardon. Can you make the screen larger? I post
Yes,
larger.
sir. Sure, sir. Sure. Is it visible now, sir?
Yes.
Yes.
Okay. Sir, as we know, at 11.59% of deaths globally and 5.65% of dialysis globally, stroke is one of the leading causes of both mortality and death. Similarly, it is also a higher. It has also a higher share of deaths and dialysis in India also. So, and with a large population of India at around 18% of the global population, and the current epidemiological transitions in the country, the systematic understanding of the stroke in India becomes a very important point for planning and planning the prevention strategies. So with this in background, we analyze the epidemiological data and the burden of stroke in India using the prevalence and the dialysis with the GBD data. So for the methodology, we use the global burden of disease data of stroke for India in 2017. And the data was analyzed for different parameters like dialysis, proportion to total dialysis, prevalence, decadal trends, gender and age differential, and the burden across states was also calculated. The data was entered into the Excel sheet and was analyzed. So coming to the result, as you can see, India, the total global dialysis attributable to stroke in India is around 13.3%, and it is the sixth leading cause of dialysis in India. It was and the total dialysis attributable to only CVDs is around 20. Among total dialysis attributable to CVDs in India, stroke contributes to more than 25% of the total dialysis. Now, coming to the decadal trends, we can see that there has been a constant increase in the stroke prevalence over the years, and till 2013, it was the males leading the females. The numbers were higher in males than females, but after 2013, it is seen that the females have a higher stroke prevalence. We can see in India. Similarly, in the stroke deaths, the males were leading till 2015, but at 2017, we can see that the males and females are at almost the same similar levels. Coming to the prevalence of stroke by age groups, the age group beyond the 45 years of age is more vulnerable to the prevalence of stroke, whereas the stroke, in case of stroke deaths, the maximum number of stroke deaths occur after the age of 70 years. Coming to the state-wise differentials, we can see for the prevalence of stroke per lakh population, we can see that states like West Bengal is having the highest prevalence of stroke per lakh population, whereas the state of Arunachal Pradesh had the lowest. Arunachal Pradesh and Mizoram. And prevalence. And while looking at the stroke deaths, we can see that West Bengal again leads the stroke deaths per lakh population, and it is the state of Mizoram has the lowest stroke deaths per lakh population. Now, this has shown that stroke has emerged as an important public health problem, and it has contributed substantially to the total burden of disease and mortality of India. And the prevention strategy has to account for various differentials like age, gender, and also through a life course approach, we have to approach this disease. And also we have to look towards the state specific variations also has to be taken into account. Thank you.
Thank you so much, sir. Now I request our chairperson to put up the questions.
Have you any idea what is stroke in young?
Hello.
Yeah, have you any idea what is stroke in young?
Stroke in young, like numbers, sir?
No. Stroke in younger age groups.
No, sir.
We don't have any spike in the graph as
Yes,
far as I can see.
Yes,
But
sir.
you showed the high prevalence, high incidence rather states, including
Yes, sir.
Kerala, where stroke in young has become a big problem. Younger people getting stroke,
Okay,
like
sir.
40s, 30s.
Okay,
Have
sir.
you addressed that? Coming from NIMANS, you should be having some kind of idea.
Sir, that's the thing, sir. Life course approach has to be the go-to method, sir. For if we are seeing at stroke at young age group, so it is a cause of concern, sir. Because
So how
usually,
early we should intervene in terms of preventing?
sir, it has to be, sir, prenatally only, sir. Like you should approach that only prenatally only. You should start
Can you
because the
explain that?
hypertension. So like
Prenatally?
like sir, the old age, sir, like the mother's food and health, sir. Mother's while pregnancy, sir. So
No, we are
like
seeing a kind of a disconnect actually. There are obese mothers and low birth weight children,
yes, sir.
especially in more educated groups.
Okay, sir.
Is that a cause for these kind of epidemiological changes? I'm waiting for the other chairpersons to put in their questions.
Okay, that I have no idea, sir. I will look into it, sir.
Okay, thank you. Sir, Neelam sir.
Hello.
Yeah.
What are the other comorbidities you have come across in this study?
Sir, the usual risk factors, we didn't look at all the risk factors because we only looked at the age and what are the age groups, basically including that, and other risk factors we didn't include in, sir.
Okay.
Thank you.
Hello, Dr. Ajit.
Yes, sir.
I want to ask you, you have shown very nice presentation, and as
you,
per result you showing, it showed increase in different age groups. So as a public health person, I want to ask you, what what intervention, yeah, what important policy change should be drawn from this data? So, what, as a
Sir,
public health person, what you will analyze from the data and what you will make change in a public because we have the program also for the stroke management and
sir,
non-communicable.
sir,
So,
one thing, yes, sir. Yeah, continue, sir.
yeah, you please tell me
Yeah.
what will be use of this data for a policy change.
Okay, sir. Sir, one thing is that we can see, sir, since the age group has one huge impact, we can we have to strengthen our screening services, sir. So it is already on, but as we know, in India, or not all things are well monitored and all. So that monitoring, that screening process has to be more strengthened, sir. In case of the NPCDCS program, the NCD clinics, so that screening thing has to be more more pakka, more uh, improvised, sir. That is one thing.
No,
Second,
this is all level of services, or you're talking about only for primary services? Because I think in secondary tertiary level there are very good services for stroke management, but whatever you are saying, that is
yes, sir.
applicable for the primary services only, primary level.
Yes, sir. So,
So what about
first, yeah, that should be the first thing, sir. It should start from that. Also, sir, look at that we have to maintain a stroke registry system that has to be strengthened more. It is there, but we have to improvise it more, and we should look at all, including all those who are inside that stroke registry, and provide the rehabilitative services so that the stroke deaths could be avoided.
do you think that there is a urban and rural disparity for this kind of non-communicable disease?
Yes, sir.
So any specific for that?
The one thing is that we are most of the programs in India are looking at improving the health of the rural, but somewhere on down the line we are missing out the urban health population also, which are more prone to the uh, what we can say, the risk factors, including the diet and the lack of physical activities, which are assumed to be more in the rural areas. So that urban pocket of the population is also getting missed out. So we should look at that also when we are planning for any programs regarding stroke, hypertension, or anything, sir.
Thank you.
Thank you, sir.
Thank you so much, sir. Sir, please stop your screen sharing.
Thank you. Okay.
Good morning, everyone. Am I audible?
Sir, your registration
Very much,
number.
yes.
Sir, please tell your
My
registration
registration
number.
number is 245.
Okay, sir, you may start, sir.
Okay. So good morning, everyone. The title of my study is The Prevalence of Obesity and Associated Factors Among School-Going Adolescents, Boys in a Rural Area, Delhi, India. So coming on to the introduction part, as we all know that obesity is a global epidemic. Obesity and associated factors have become an increasingly important medical problem in children and adolescents. Evidence shows that obesity begins in childhood and its associated risk factors like low physical activity, unhealthy eating habits also emerging at the school going age. So India is undergoing an epidemiological transition where non-communicable are on the rise as compared to the communicable diseases. So obesity and associated risk factors contribute to the growing burden of these non-communicable diseases. So what was the rationale behind conducting this study was that the most of the studies which was checking the prevalence of obesity among school going boys were in the urban areas. So this study was concerned in finding the prevalence of obesity and associated factors among the school going adolescent boys in a rural area in Delhi. So there were the two objectives of this study. First objective was to study the prevalence of obesity among school-going boys in rural area of Delhi, and the second objective was to find out the associated factors associated with obesity among the same population. So coming on to the materials and method, the study design was a cross-sectional study. The population was adolescent boys of class 9, 10th, 11th and 12th. Study area was a government boys senior secondary school located in Najafgarh, that is a rural area in Delhi. So study period was for 1 year. The sample size was calculated using the formula for cross-sectional study, that is 4 pKyl square, and it comes out to be 600 after addition of 10% of non-response rate. Those sampling method which was followed in this study was stratified random sampling. So there are 4 government boys senior secondary school. So these 600 sample was taken from all those 4 boys government boys senior secondary school. So these 150 from each school. So there will be 600 in these 4 government boys senior secondary school. And these 150 will be divided among the 9th, 10th and 11th, 12th class. So 38 students from each class. And the questionnaire which was used was pre-tested semi-structured modified WHO step questionnaire was used. So coming on to the result part, in figure 1, we can see that the majority of the students were belong from 14 to 16 years of age group. In figure 2, we can see that according to the socioeconomic status, the maximum number of students belong to lower middle and the upper middle class. In figure 3, we can see that if we combine the percentage for overweight and obese, it comes out to be 11.40, 13.40, which is a quite high percentage. In figure 4, we have taken the level of physical activity and then we compare it with the associated factors with the obesity also. So the prevalence, if we see the percentages, the physical activity was very high. And in figure 5, if we see the prevalence of hypertension, it was pre-hypertensive was 7.30 and the hypertensive were around 4.30. And we have also taken the family history of hypertension also, and the prevalence of hypertension was 28.20, the family history. In table 1, if we see the associated factors with obesity, I have included only the most common factors which I have seen the association. And if we can see that the factors which were significantly associated with obesity was consumption of junk food, family history of hypertension, consumption of less than 5 servings, and the high blood pressure was associated with obesity. So the conclusion part was the prevalence of the obesity was was high among the adolescent boys of rural area of Delhi, and the factors like consumption of junk food, family history of hypertension, less than 5 servings, and the presence of high blood pressure were the important risk factor which were associated with the obesity. Thank you.
Dr. Sunil?
Yes. Yes, Dr.
Yes, I want to ask you, which criteria you use for the BMI classification here?
So BMI classification, we have used the growth standard, WHO growth standard median. So if the overweight was classified greater than 1 standard deviation above the growth standard, WHO growth standard median, and obesity was greater than 2 standard deviation, and underweight was less than 2 standard deviation.
Okay, and for socioeconomic status, you are not mentioned scale use?
It was a rural area, so we have used the modified BJ Prasad classification, per capita income.
My question will be which BMI classification, I mean the standard for BMI, which study was dependent on, the rural oriented WHO standards or the normal one which everybody is using?
Sir, actually, we cannot use the normal BMI classification because these are not the adult population. So we have used the adolescent BMI classification based on the WHO growth.
No, which study? Which study? Is it from the developing countries or is it the watered down version of the European and Western countries?
So it was for the Indian population only. They have mentioned the different charts for there according to the WHO, and it can be used in the Indian population or the Asian population also.
Good, thank you.
Dr. Sunil.
Yes, sir.
I think you lead the girls students. Is it difficult or unfeasible to approach the girls? What is the
Yes,
reason?
sir. Sir, actually, I have to take the waist circumference also. So it will be very unfeasible to take the waist circumference, and the consent part was very important.
But you
so
can
I have
take
taken
take some your girl companion to help out.
Yes, sir. But actually, I was trying for the consent from them, the permission from the girls' school also. But the principal was not very was not ready to give me the permission, since it's a rural area in Haryana, so they are not very allow them to take the waist circumference by raising their maybe clothes, and we have to take the waist circumference, and also that's why they are not allowing me, sir.
Okay. Okay.
Thank you so much, sir. Now I would like to invite Manya Prasad, our next speaker. Please share your screen, sir.
Thank you, Nitesh. And I'm a female. So thank you. Thank you for inviting.
Sorry, ma'am.
Yeah, no problem. So I think Dr. Sunil will have to sharing.
Dr. Sunil, please stop sharing your screen.
I have stopped it, I think.
No, we can still.
But it's visible here. Please stop sharing. Okay, thank you, sir.
Dr. Manya, your number, registration number?
Good morning, everyone. My registration ID is 87. 87. Okay, so good morning again to all the chairpersons and all the attendees and panelists. My name is Dr. Manya Prasad, and the title of this poster presentation is Spiking.
Hello, Dr. Manya, can you please enlarge the screen?
Okay, sir. I think I will have to zoom in. Is it better?
No. You have to, previous was better, but just enlarge. Yeah, now it's better.
Okay. So the title of this poster presentation is Spike in Particulate Matter is a triggering factor for the occurrence of stroke. And this is a systematic review and meta-analysis. So the introduction, many studies have reported increases in daily cardiovascular mortality and hospital admissions associated with increases in levels of air pollutants. And the mechanism for this is many-fold. So they have proposed mechanisms like changes in endothelial function, vasoconstriction, and blood coagulation, and so on. However, so far, there is no decisive evidence on air pollution being a triggering factor for stroke. And it is important to study this because of a number of reasons. It can help to improve our predictive models and risk stratification, as well as devise improved preventive measures. So this systematic review and meta-analysis was undertaken to determine whether there is an association between spike in particulate matter and incidence of stroke, and the type of stroke that we studied was ischemic stroke. Coming out of the methods, we performed a systematic review of case crossover studies, evaluating whether levels of particulate matter, that's PM 2.5 or PM 10, is associated with short-term risk of ischemic stroke. So case crossover studies are a modification of the case control design, where every case serves as its own control. So it's a within subject comparison. And so control periods are compared with hazard periods instead of comparing cases and controls. So the databases that we searched were PubMed, Embase, Cochrane Central, and the dates were from January 1966, so inception, to October 2019. Two reviewers independently identified studies that met the inclusion criteria, and the software that we used for the meta-analysis was RevMan 5.3. Summary effect measures and 95% confidence intervals were calculated, and the method used was the generic inverse variance weighted random effects model. Heterogeneity was examined both statistically as well as by visual inspection of the forest plots to see for overlap of confidence interval and the I-square statistic. Coming on to the results, so the systematic review included 8 independent case crossover studies. I did not have space here to present the data abstraction table, but I can tell you verbally that the studies were from France, China, USA, UK, so there was some amount of clinical heterogeneity in the type of particulate matter that they studied. So most of them studied PM10, and the type of patients that they took were either hospitalized stroke patients or those from registries, stroke registries. So the meta-analysis showed a significant association between increased levels of particulate matter and incidence of stroke in the following 24 hours. And the odds ratio, the pooled odds ratio is 1.21. So there's 21% increased odds of developing stroke in the 24 hours following the spike. And the confidence interval is from 1.02 to 1.44 with a p-value of 0.03. There was evidence of substantial heterogeneity between the studies, and the I-square was 95%. And the reasons for this could be due to systemic differences in the baseline characteristics of the adult population, as well as differences in the measurement of pollutant and outcome. So as I said earlier, there was significant difference in the type of particulate matter that they studied, and probably the type of stroke patients as well. So in conclusion, the acute exposure to air pollutants may be associated with an increased odds of occurrence of stroke in the 24 hours following spike in PM10 and PM2.5. And I will just show you the forest plot here. So these are all the studies that were included. And looking at the forest plot, we can see that most of the heterogeneity that was there was due to the magnitude of the effect rather than qualitative heterogeneity due to the direction of the effect. So a part of the I-square can be explained by this, and these are the references. Thank you.
Thank you so much, ma'am. I request chairperson to please ask the questions.
Hello, Dr. Manya.
You won't answer the question, he'll ask the question. Hello, Manya.
Yes, sir.
Okay, so it's a case crossover study, systematic review, and then you took the data from published articles, and we find that the 24-hour incidence of stroke increases after the PM 2.5 and the PM 10 increasing, isn't it?
Correct, sir. Yes.
So we see that stroke generally has got some peaks and all that to climatic changes, especially wintry mornings and all that is supposed to be bad for embolisms and all that. So is it just particulate matter which is causing it? Because with winter comes inversion and pollution increases. So is it an independent effect of pollution, or is it something else like the temperature variations? The other factors. Probably winter brings on fevers. NSAIDs are supposed to be associated with problems with regard to cardiovascular system and all that. Do you think the effect which you have demonstrated is independent, especially that the studies are not different in terms of weight? Actually, the study weights are actually somewhat comparable, but the effects are going all over the place, and probably the biggest studies are actually not showing the kind of effect which we expect. So how do you put that all into one conclusion?
So thank you for that question, sir.
Thank you.
Answer that in two parts, seeing that the two different questions. The first part relating to whether there's confounding by other factors like weather and so on, temperature, etc. So that inherently depends on how the included studies were able to eliminate bias. Now, one of the inherent advantages of a case crossover study is that within person confounding does not happen. So all of the factors that could probably be a confounder within one person is taken care of. The rest of the factors, like whether they were able to, they at least attempted to eliminate by taking a control period which was around the same time of the year. So the hazard period was 24 hours before, and the control period was the same day the previous year. So they did have some mechanisms to try to eliminate time variant confounders as well, but I totally agree that there are inherent limitations to an observational design, and we cannot eliminate confounding completely. The second part of the question was related to the weight of the studies. Now, the weight depends on two things. One is the sample size and one is the effect size. So sample size was, I agree that it was more or less similar across studies. But the effect is varying quite a lot, but most of the variation in the effect is the size of the effect rather than the direction. So that could possibly be one reason why there is high heterogeneity as well. Thank you.
Dr. Manya, was there any study included from India in this?
No, sir, there was no study from India. There were two studies from China, two from France, two from USA, one from UK, and I believe one of them was from Japan.
Okay.
Thank you so much, ma'am. Ma'am, please stop sharing your screen.
Thank you, Nidhi.
Now I request our next speaker, Dr. Nidhi. Please share your screen among us.
Yes. Good afternoon, everyone. Am I audible to everyone?
Yes, ma'am. Go ahead.
Okay, thank you. I'm Dr. Nidhi Sharma, PhD scholar, AIMS Rishikesh. I'm presenting a poster titled Fluorosis and Geological Pattern of Rock in District Rudraprayag, Uttarakhand. Fluorosis is a crippling disease that is caused by excessive intake of fluoride, mainly through drinking water. That means that drinking water is a main cause of fluorosis. When the groundwater percolates to the rocks, which are composed of fluoride-rich compounds, then fluoride leaches out from them, and concentration in water may increase above the safe level. And when person are drinking that water, which is having more than permissible limit of fluoride, that results in fluorosis. Thus, the geological pattern of any area could serve as a guide for the occurrence of fluorosis in that area. That is what is the basis of this poster. This study also was done in Rudraprayag, and a similar result was predicted through the geological analysis also. So when we first see in the center, there is a map that defines the geology of the Rudraprayag district. Geology is actually the rock pattern of the area. Then we can see there are marks in the map, some yellow dots, some black dots, and some red dots. These are the villages that were selected for my study in this area. They are 30 villages. The background in the background, the change in color of the map is actually a rock pattern. This is a different rock pattern. This is lime and quartz. This is granite. These are different rock patterns in this area. Now, when we go further, when we see this area is actually made of lime and quartz, and the villages in this area, they have a fluoride level of less than 0.6 ppm, and the prevalence of dental fluorosis was 0 to 1.5
1.5%. These villages
Voice is
were
breaking.
the fluoride level was, the dental fluorosis was 0 to 1.5. Okay. Is it clear right now or not?
Yeah, it's clear.
Yeah, it's clear.
Okay. When we analyze this area, in which that is dotted one area, this area was composed of lime and quartz rock. The fluoride level in this area was less than 0.6 ppm. And the dental fluorosis which was observed in the population was 0 to 1.5%. And as well as the severity of dental fluorosis, which can be seen in these graphs, was very less. That is, the people who were having fluorosis was 0 grade fluorosis, this one. Then we move to the next area. In this area, the rock was composed of prophylactic rock and Genesis rock. And that was having very little component of granite. In this area, the fluorosis was 0.6 to 1 ppm in between. The fluorosis pattern, dental fluorosis prevalence was between 21.2 to 66% prevalence. And the severity also was most of the patient was suffering from a grade 3 or grade 2 level of fluorosis. And the zero grade was slightly less than the previous one. And then we come to the area which were made of granite. Actually, this area, these were all made up of granite rock. When we visited villages in these areas, the fluorosis pattern was the water fluoride level was more than 1.5%, and the
Your voice is breaking.
fluoride level was more than 1.5%, and the prevalence of dental fluorosis. When we now it's clear.
Yes.
Now the last one of the villages that was visited were in the granite region. This region, in these region, the rock was mostly composed of granite rocks. Here the fluoride level was more than 1.5 ppm, and the dental fluorosis prevalence was more than 90%. And when we see the severity of fluorosis cases, most of the cases were from 4 and 3. The severity was 4 and 5 grade of dental fluorosis. So the conclusion is this study suggests a positive association of presence of fluoride-rich rock around the water source and prevalence of fluorosis in the population of the area. And furthermore, based on the finding of this study, the geological map of each district of a state may help in occurrence of fluorosis disease in respective district. Thank you. Okay.
Your number is 400, right?
Yes, sir. My number is 400.
And I suppose you are a dental surgeon.
Yes, I am a dental surgeon.
Okay. Yesterday we saw the presentation by Vartika ma'am.
Yes, sir. Yes, sir.
Okay. Ma'am also was telling about the rock pattern and all that. I thought, granite will be the most difficult to leach in terms of, dissolution and all that. Other rocks are actually more friable, and then, leaching quality will be much worse, I thought, but it looks to be counterintuitive. Any explanation for that?
Yes, sir. Sir, leaching quality of lime and quartz is too high, but actually these rocks are not rich in fluoride. So even if they leach in their water, they can increase the calcium level, but they cannot give a fluoride level high. The fluoride level are high in granite rocks because they have fluoroapatite crystals in them. If these rocks leach, they will lead to a higher fluoride levels.
Okay, the second question is, when the dental fluorosis is so high, we would expect some kind of skeletal fluorosis and, paraplegia and stuff like that. Do you find any
Yes,
connection?
sir. Yes, sir. Dental fluorosis was high, but when we see the water level, the maximum, the highest level what I observed was 2. And normally for the skeletal fluorosis, a level of around 4 was predicting skeletal fluorosis. Although some of the cases which were aged patients, and the urine analysis of those patients showed that they have body fluoride level of 6 milligram per liter. They were showing some features of skeletal fluorosis, but we cannot do the radiological examination and cannot differentiate it from other orthopedic problems. That's why skeletal fluorosis is not confirmed. And when we see other studies, most of the studies says that above 4 ppm level only, skeletal fluorosis become prevalent in the
And
population.
curiosity point of view, fluoride, is it excreted as organic compound in the urine, and how do you actually get around that problem of analysis? I saw your machines.
Yes, sir. It's actually we use a buffer in it. It is
Okay.
it mostly combined with calcium in the body, and in urine also as a crystal. It is with combination with aluminum and chloride complexes are passed through.
So you can do point of care analysis, is it?
Sir?
You can do point of care analysis.
Yes, sir. We can do.
Okay.
Yes, sir. Because we have buffers, the buffer that disintegrate the complexes.
Okay.
And then fluoride become as an ion, free ion.
Okay.
When we observe in
And
it.
one more curiosity, what is the area's DMFT index and all that?
So DMFT index, yes, sir. It's a very remarkable finding in these areas. But the areas which are having high level of fluoride, the DMFT index was very low. And even I have presented an oral presentation in recent days only. In those areas where the fluoride level were very high, the DMFT index was very low. And in those areas which were like if we are having fluoride very low, the DMFT index was very high.
Okay.
Especially when the range was less than 0.3 ppm, the
Okay.
DMFT index was very high. And when the range was more than 8 ppm, the DMFT index was slightly lower at that range.
Fantastic. Okay. One more thing, my dental friends, they used to be talking about, we should not be marketing fluoride toothpaste.
Yes, sir. Yes, sir.
Do you subscribe to that, or are you for a differential distribution in terms of fluoride content in the area?
Yeah. Yes, sir. For the country like India, there are many places where groundwater is having high fluoride. So, giving fluoride toothpaste as a mass level is not a good recommendation for countries like India.
It should be given to only children in the growing stage.
It should be given. Actually, fluoride has many uses. It can be used as a topical application also when you apply over the tooth surface. So, giving it to any specific age group, it should not be given below 5 years. That is for sure, because injection of fluoride can be harmful for them. But above 5 years, it can be given in a toothpaste because it has some topical applications also.
Okay. Thank you so much. All the best.
Thank you, sir. Thank you so much.
Thank you so much, ma'am. Sir, actually, sir, we are exceeding the time, sir. Sir, we have only 5 minutes and one last speaker is left, sir.
Hello.
Ma'am, you please stop sharing your screen.
Okay.
Now we have our last presenting author, Dr. Sanjeev. Sir,
Hello.
Yes, sir. Sir, start sharing your screen, sir.
Yes.
Over to you, sir.
Is it visible?
No, sir.
Is it visible now?
No, sir. No, sir.
Actually, I'm presenting from
It
my
is not
mobile.
visible.
Actually, my laptop is not there.
Actually, it is not visible. Still not visible.
It's not visible, sir.
I'm presenting from my mobile actually. Hello.
Last, sir, in case slides visible.
Okay, can I speak? Do you have the slides from your own side? Actually, hello. You might be having slide from my side. Can you present from your own side? Present those slides. I will just speak out. Is it possible? Hello.
Yes, sir. Yes, sir.
Just
Yes,
hold
sir.
back. Just hold back. We are doing it. Just hold back.
Hello. Hello.
Go ahead.
Hello.
Go ahead, G.
Hello, Dr. Sanjeev.
Whether my
Your
slides are
voice,
visible?
No.
slides are not visible, but your voice is audible.
I think there is some technical problem from my side. Yeah.
Now it is visible.
Is it visible now?
Visible. Yes, it is visible.
Yes.
03.
Yeah, the topic of my presentation was to see to explore one of a different kind of topic, which I wanted to explore that there are many modalities which are coming for new diseases. There are many modalities which are coming for the non-communicable diseases from the treatment. Yes, natural approaches and as well as spiritual approaches these days are coming. So we tried to see what could be the effect of or the impact of this kind of activities in the form of spiritual chakras healing, which can it help us in reducing the non-communicable diseases. This I tried to do in the form of a panel study. We also know that panel studies are those studies we carry out series of cross-sectional studies on the same patient. So for this, what we did, next slide. Hello, next slide. So for this, what we did, we tried to see the effect of these various spiritual chakras, which are discussed by various spiritual healers. Like the chakras are the wheeling circles of energy situated at from the base of the spine to the top of the head. So we try to see what is the effect of the healing of these chakras. Can it help us in reducing the burden of the non-communicable diseases? So as in India, we are having the epidemiological transition. We both have communicable as well as non-communicable diseases, and communicable diseases are also rising. So we try to see that whether by healing the chakras, those who were attending these healing chakra healing sessions, whether out of those people having this non-communicable disease, whether they improved or not. So this we tried to see in our study. So for this, the study we carried out in the form of a panel study, and in this panel study, what we took I took an institution which is known as Institution of Spiritual Sciences in New Delhi. This is situated in the Ramesh Nagar, and in that we took the sample of not sample. We first of all we selected 500 people, those who attended the spiritual chakra healing sessions. And out of those sessions, we tried to identify how many of them had non-communicable diseases. And out of those non-communicable diseases, how many of them have improved? Especially the three diseases we took in this case, the diabetes, hypertension, and a hyperthyroid state. So this we tried to see, and we found that the good percentage of patients, they were having improvement in their disease state, like in the improvement in the hypertension, reduction of the hypertension, improvement of the glycemic state, and as well as improvement of in the thyroid status. So this we tried to see in our study, and we found that they were good in that. Basically, we found 87 people out of 500 who were having this non-communicable diseases. Out of them, I think 37 were there for this for the hypertension, and 23 for diabetes, and nearly for some this 37 for this. So this we try to see that these people reported that their symptoms got improved with after attending this spiritual chakra healing session. So this was a very preliminary or a very exploratory kind of thing which we try to see whether this can be one of the future approaches. Can we think of these kind of future approaches? The study, I can only say that this is just a simple kind of study where we can think of newer approaches. So this was the main aim of the study, and we found that there was significant improvement in these kind of people. This is all that we tried to see in that. Hello. Hello.
Thank you so much, sir.
Number is 6, I think. 3.
My registration number is 3.
3.
You can send it to us. Can we proceed to the next session, sir? Or if there is any question, sir, you may ask to the participants.
Thank you, my colleagues and presenters. Thanks.
Thank you so much, chairpersons and speakers, for the enlightening the session. Now we are enclosing the session and moving towards next session.
Thank you. Thank you.
Thank you so much, sir. Thank you so much.
Thank you so much.
Good afternoon, everyone. Sorry for the delay in the session. Now we will starting with the next session on EBPH. And we have Dr. Ravleen Kaur Mishra. Sorry, Dr. Ravleen Kaur Bakshi. Dr. Ravleen Kaur Bakshi, she is MD in Community Medicine, Diploma Applied Epidemiology. She is working as a scientist in the Division of Reproductive Biology, Maternal and Child Health, Indian Council of Medical Research, Department of Health Research, Ministry of Health and Family Welfare, Government of India, New Delhi. Now, ma'am, we don't have I guess, a second chairperson for the day. Dr. Pankaj Kumar Mishra couldn't join due to his previous appointment. So, Dr. Ravleen, ma'am, if you could hear me, can we proceed with the poster presentations for the day?
Just 1 second. I'll give me 1 minute, please. I'll join again.
Dr. Ravleen ma'am, are you there? Sorry for the delay, participants. Let the chairperson join again. I guess she lost her connection. Dr. Ravleen
I've
ma'am, are you there?
joined Dr. Nandita. I've joined. Hello, Dr. Nandita, can you hear me?
Yes, ma'am. Shall we proceed?
Okay. Yeah, please.
Okay. So good afternoon, everyone, once again. So we'll be starting with the presentation of Dr. Vinayak Mishra, and his title is Prevalence, Pattern and Correlates of Technology Use Among School-Going Adolescents in a District. Dr. Vinayak, can you please share your screen? And sir, if you are unable to do so, you can ask us. We can share your poster from here. Dr. Vinayak, are you there? क्यों नहीं रहे लोग? इतना delay. हाँ. Dr. Vinayak, are you there, or should we proceed with the next presenter? We are unable to connect with Dr. Vinayak. Then we should proceed with the next presenter. Our next presenter is Dr. Mosmi Datta, and her topic is a study on excessive daytime sleepiness among female students in a postgraduate institute of Kolkata. Over to you, Dr. Mosmi. Kindly start with your presentation. Any other presenter who would like to present this slide first? Please go ahead. I guess we are unable to connect with the participants. Dr. Amanpreet, would you like to present your poster? We can see you among the panelist list, but I don't know, ma'am. Dr. Ravleen, ma'am, are you able to hear me? Am I audible?
Yes. Yes, you are audible.
Dr.
Any of the
Amanpreet,
participants who are there can start. It's okay.
I can see them among the participant list, but I don't know, they are not responding. Any participant, please proceed.
Yes, ma'am. I want to present.
Okay, go ahead.
Dr. Pramod, please, there's some background noise. Please see to it that there's no background noise. You could share your poster in a PPT mode or put it on a slideshare mode so that we could easily see it.
Hello.
Yes, Dr. Pramod.
Yes, ma'am.
Please start.
Am I audible?
Kindly present your.
Ma'am, am I audible?
Yes, you are
Yes,
audible.
you are audible.
Okay, ma'am. Thank you. My topic is macrocytosis is highly prevalent in Raebareli district, Uttar Pradesh, India. Hello.
Yes, please continue, Dr. Pramod.
Okay, ma'am. Ma'am, as you know that anemia is a global public health issue and that is occurring more than 1.6 billion in all over world. But in Raebareli district, there is a major problem of anemia, and we consider that we studied the more than 1,300 patient for anemia population.
Okay.
And yes, ma'am.
Continue, please.
Yes. And we collected the sample in our OPD along with our lab collaboration, and then we studied that there is a more than 55% of anemia population are macrocytic.
Okay.
And during this macrocytic picture, if you see that male prevalence is very high, and that occurring approximately 65% macrocytosis. And female population is less, approximately 1/3 of total of macrocytic population.
Okay.
And on the behalf of causes, if you know, I think the total macrocytic population in Raebareli district is that anemia consider approximately 7% of.
Your voice.
Hello. And total anemic population in macrocytic population of Raebareli district is approximately 7% male. And approximately 23% in female. But there is a most cases are macrocytic population that are not anemic, not non-megaloblastic, anemic. And that population in consideration of male population having the most common causes are alcoholic or smoking, tobacco abuse. And in case of female, there is a much chance of non-anemic macrocytic female are due to pregnancy. Mostly male of younger to middle age are susceptible to the non-anemic macrocytosis due to alcoholism and smoking. in this region, pregnancy was appeared as a major factor contributing the macrocytosis in female due to folic acid B12 deficiency. Hello. Hello, ma'am.
Dr. Pramod,
Yes,
your
ma'am.
voice was breaking when you were explaining the pie chart. Can you again explain them once? Your results. Figure 1.
Okay, ma'am. And figure 1, figure A is that is the population that we have taken for study, in which anemic population is percent of total population. In this total anemic population, more than 55% patients are macrocytic. Sex-wise distribution is the 65% of macrocytic patients are male and 38% in female. That is the figure C and D. And when figure 2 may, this is a figure 1, is the total macrocytic population in male having only 6.9%.
Okay. Fine. Dr. Pramod, what do you conclude from your study?
Now we conclude that the macrocytosis is higher in our district in Raebareli.
What do you conclude from your study?
Yes, ma'am. Macrocytosis is higher prevalence in Raebareli district, and most of the time non-megaloblastic macrocytosis is higher in male population due to alcohol use, tobacco abuse, smoking, and also in female there is this prevalence is high because of due to pregnancy, despite of anemia.
What are the research gaps which you have recognized in your study, which would like to further investigate after you have done this study?
Ma'am, research gap that is
Dr. Pramod?
Yes, ma'am.
Yes, please.
Basically,
after this study saying that microcytosis is highly prevalent in Raebareli,
yes, ma'am.
In males as well as females, in males due to alcohol and smoking, and in females during their pregnancy.
Yes.
And it is a major cause of anemia. That is what you're trying to say from the study. And then what is the way forward? What after doing this, what should we expect from this study? Like,
basically, there is a alcohol abuse and smoking, tobacco use is much higher in this side, I think. So if we can consider these issues, then we can prevent the macrocytosis.
okay, fine.
Thank you, ma'am.
Thank you, Dr. Pramod. Dr. Nandita, next speaker, please.
Okay, next we have Dr. Amanpreet Kaur, and her title is A Study of Training Needs, Assessment of Doctors and Nurses, and Approaches to Performance Improvement. Dr. Amanpreet, please proceed.
Yeah, yes, please. Yes. Good afternoon, ma'am. Is it visible? The screen is visible?
Yes, it's visible, but please put it on slideshow. Slides.
Dr. Nandita? Dr. Nandita?
Yes, ma'am.
What was the registration number of presenter? Dr. Pramod? Can you just...
Ma'am, it was 144.
Or is it some other number?
Dr. Pramod, can you confirm with your registration number? It is mentioned 1.4 here.
144,
Ma'am,
144.
Yes.
Yes.
Okay. Thank you. Thank you.
Can I start, ma'am?
Yes, please.
Good afternoon, ma'am. My study is a study of training of doctors and nurses and approaches to performance improvement in a tertiary care hospital. So we all know training has a distinct role in the achievement of an organizational goal by incorporating the interest of organization and the workforce. Training and development is an attempt to improve current or future employee performance by increasing an employee's ability to perform through learning, usually by changing the employee's attitude or increasing his or her skills and knowledge. So the objective of training would be achieved by first carrying out a training needs assessment or analysis, which is the process of identifying training needs in an organization for the purpose of improving employees' job performance. TNA is an effective method to determine who and what should be trained based on the perspective of users when planning in training and development. So the purpose of this study is to assess the training needs of the hospital employee and the approaches to improve their performance. The objectives of the study are to identify the training needs of the doctors and nurses in a hospital, to prioritize these training needs, to compare the training needs of doctors and nurses, and to identify the approach to improve their performance. The study was conducted in Shri Guru Ram Das Hospital, Walla, Amritsar, Punjab. It was conducted among doctors and nurses of the institute. It was a cross-sectional study and convenient sampling method was adopted. A total of 100 doctors and nurses, 50 each, from different specialties of Shri Guru Ram Das Hospital, Walla were contacted. And the World Health adopted Hennessy-Hicks Training Needs Analysis Questionnaire, a self-reported close-ended structured questionnaire with a core set of 30 items was used. These items refer to tasks that are central to the role of healthcare professionals and are categorized into 6 superordinate categories, which are research, communication or teamwork, clinical skills, administrative skills, managerial or supervisory skills, and continuing professional education. Each item in the questionnaire is rated along a 7-point scale in 4 different ways. The first way, rating A, is how important a task is to the respondent's job. What he perceives about the task, how important it is to his job. And second, rating B is how well the task is currently performed by them. And third, rating C is how far the respondent believes that the training need can be addressed by organizational change, or they believe that it can be addressed by training courses. So interpretation of the ratings. So we have compared the averaged group scores for importance and performance, which provide an assessment of where the greatest training needs lie. The greater the difference in scores, that is average group scores of rating A and B, which were importance and performance. If there is greater difference, it means the greater is the training need. And the way in which particular training need could be addressed is identified by the scores given to rating C and D. If more is rating C, then it means they want some change in the organization to improve their skills. If more given to rating D, it means they need some training course to improve their skill. And then results, just wait. So first graph shows the training needs for each category of task. Here we can see the highest training need is there for research activities. And another is for supervisory task, then for clinical task. And another are for the lower ones for communication skills and administrative tasks. So here we can see the highest training need is for research activities. So they need to be trained in research to do practice the evidence-based medicine. The next is the importance of different tasks as perceived by the respondents. Here we can see the doctors perceive the importance more than the nurses for the supervisory task, administrative task, clinical task, research and communication skills. And for the performance, we can see in supervisory tasks and administrative tasks, the performance level of nurses were better than the doctors. And for clinical tasks, research and communication skills, the doctors' performance was better than nurses. Then for both the groups, we found that priority training needs. Here also we can see for research activities, the training needs, we have to give more trainings to both doctors and nurses. Because highest training need is for doctors, it comes out to be 2 and for nurses 1.6. And clinical tasks 1.3 and 1. And then administrative tasks 1.5 and 0.6. And for supervisory tasks 1.4 and 0.9. So conclusion, on assessment of training needs of doctors and nurses, it was found that there is maximum training need required in research activities because average difference score between rating A and B was found to be 1.5. It was highest among all the ratings, followed by the supervisory or managerial tasks and clinical tasks. But although clinical skills are must for the quality care of the patients, so the doctors and nurses should be kept updated regarding latest advancement in clinical fields through trainings. Thank you.
Ma'am, any questions from your end, or should we proceed with the next one?
Dr. Amanpreet?
Yes, ma'am.
Hello, am I audible?
Yes, ma'am.
Dr. Amanpreet?
Yes, ma'am.
It was a nice presentation.
Thank you, ma'am.
I just want to know why you did not have a focal group discussion and you thought of doing a questionnaire method here?
Ma'am, because I had 1 year to complete my course, so you can say because of time constraint, I have selected this sampling, this method to just go and interview them and collect the data.
Okay.
Thank my thesis. So,
what is your number, Dr. Aman?
119.
119. Okay. Thank you.
Thank you, ma'am.
Thank you, Dr. Amanpreet. Now we'll have our next presenter, Dr. Vinayak, and his topic is prevalence, pattern, and correlates of technology use among school-going adolescents in our district. Over to you, Dr. Vinayak.
Hello. Am I audible, ma'am?
Yes, sir, you're audible.
My screen also visible, ma'am?
Yes, it is.
Okay. Thank you.
Kindly start.
Sure, ma'am. Good afternoon, everybody, ma'am. Good afternoon, ma'am. Myself, Dr. Vinayak. I'm pursuing my master's in public health from Nimant, Bengaluru. Today, I'm presenting my study like prevalence, pattern, and correlates of technology use among school-going early adolescents in a Kolar district, Karnataka. We know that technology has become an integral part of our daily life and offers substantial variety of platform for different perspective, like for information, communication, education, and entertainment purpose. Even though the use of this technology were helpful, they turn out to be equally harmful when used excessively and inappropriately. Without our knowledge, they can harm and seriously affected our health. The use of technology has increased in all age groups, and increased use of technology among adolescents is also associated with technology addiction. Even though there is an urgent need to develop and strengthen programs for healthy use of technology among adolescents, they are currently hampered by limited research in this area. With this background, we intended to undertake a comprehensive assessment of technology use among school-going adolescents in Kolar district, which is the Public Health Observatory of Nimans. If we're talking about methodology, a cross-sectional survey was carried out among school-going adolescents in 6 talukas of Kolar district using stratified cluster sampling. A study tool was developed using a battery of study scales that assess various types of technology use and addiction. All the scales were pre-validated for internal consistency through a pilot study. Both descriptive and inferential statistics were computed to assess the prevalence, pattern, and correlates of technology use among the adolescents. Now coming to the results, first we will talk about the technology use and addictions. Here we can say almost all of the participants were using technology in any one or other forms, which is 99.59%. Among all type of the technology, here we can see television was the most commonly used technology, followed by a simple cell phone and video games. Also, when we talk about the prevalence and pattern of technology addiction, so here we can see among all the technology users, the prevalence of technology addiction was found is 10.7% of the study population, and which was higher in cell phones. Now, the distribution of the study subject by access to technology, how they are assessing, how they are using the internet. Here we can see internet was used most of the participants by their cell phones, and how they are assessing video games, that also cell phones. And most of the participants were adolescents, and they were using their father's phone or father's phone. The purpose of use of technology was most of the participants, they were using internet for gaming purpose, and also the smartphone was used for the gaming purpose. And for desktop computer also, the gaming was the most usable person, and following by the listening the music. If we are talking about correlates of technology addiction, so here we can see technology addiction among adolescents was significantly associated with risk factors that range from individuals various levels, individual levels, family level, and also at school levels. In individual levels, we can see here with respect to gender, male have higher male have a higher prevalence. Male was higher prevalence than the females, and in the age group of the age group of 11 to 12 years were having higher prevalence of technology addictions, and rural children were having a higher prevalence. That is an interesting finding of this study. At family level, we can see the parental game playing was also associated with significantly associated with the higher prevalence of technology addiction among adolescents. And at school level, we can see that bullying and victimizations also having risk factor for technology addictions. In the conclusion part, I would like to say this study is perhaps the first most comprehensive effort so far to understand the prevalence and pattern of technology use and addiction among school-going adolescents in India. We have used, there are studies that assess the technology addiction in the mobile phone and internet, but other than that, we have assessed the other things also, like common cell phones and video games. The present study also highlights that technology addiction is a serious and emerging public health problem among adolescents. And the challenge confronting us is to develop evidence-based, cost-effective strategy to intervene and prevent technology addiction among adolescents who are exposed to technology in earlier years. There are lots of opportunity where we can improve where we can improve the situation and reduce the burden of technology addiction. These are my reference. Thank you, ma'am.
Dr. Vinayak, can you please repeat the challenges? Your voice was breaking. I mean, I couldn't hear that part.
Hello.
Hello, Dr. Vinayak. Can you hear me? I couldn't hear the challenges part. Can you just repeat it, please?
Challenges.
Yes, the challenges which you faced.
Okay, ma'am. Challenges, ma'am. First, like it was informed consent form, ma'am. First thing, like we had to take consent from the parents. That was because all participants were adolescents, so it was very challenging to take informed consent from parents. Some parents were not agree, and they were not interested. Then obtain the list from the health officers, and also like it was little difficult as. It was most of the participants from the rural area, and only it was that our study only focused on the government schools. So these were the common challenges that we faced, ma'am.
So, Dr. Vinayak, what are the biases in your study?
Bias, ma'am, we can say like social, social response, socially desirable response.
Can you hear me,
bias,
Dr.
ma'am,
Vinayak?
can happen because some questionnaire was administered in groups. So that time, like they don't wanted to show their like used. So social response bias, ma'am, can happen.
Okay, so there is another bias which you yourself have pointed out, that most of the study was done in the rural population
Yes,
of
ma'am.
a district. That also reflects in in the responses that you have got more responses in the from the rural children.
Yes, ma'am.
Isn't it? And what what were the objectives of your study? Have you met those objectives?
Huh? Sorry, ma'am. Hello.
Dr. Vinayak?
Yes, ma'am. Yes, ma'am.
What were the objectives of your study? Is first question.
To assess the prevalence and what the patterns of technology use and addiction in the school going early adolescent in Kolar district, ma'am.
Okay, so did you find addiction hampering the students, and students also realizing that they were addicted, or the parents did some parents report that our children are addicted to mobile?
Then that after this study also, like we are trying to do the FGD, ma'am, regarding that. Like we wanted to meet with the school teachers and also with parents and some participants from the adult school childrens also. So we are trying to make, ma'am, some FGDs. Because of COVID we couldn't do that, but we are planning to do that FGDs also, ma'am, so we can get the perspective of school teachers also as well as parents also, ma'am.
Okay, fine. Dr. Vinayak, what is your registration number?
Registration number, ma'am, 169, ma'am.
Thank you so much.
Thank you, ma'am.
Thank you, Dr. Vinayak. Now the next and the last participant for the today's session is Dr. Mosami, and her title is A Study on Excessive Daytime Sleepiness Among Female Students in a Postgraduate Institute of Kolkata. Over to you, Dr. Mosami.
Thank you. I'm Dr. Moushumi. I completed my MD MPH from All India Institute of Hygiene and Public Health. Am I audible?
Yes. Yes.
And I did this paper with my teachers, Dr. Deepak Pal and Dr. Sanjay Sadhuka sir. My study title is a study on excessive daytime sleepiness among female students in a postgraduate institute of Kolkata. Excessive daytime sleepiness means inability to stay alert during the major awake period of day, which resulting in falling asleep in inappropriate time. It is sleep-related symptoms and very common symptom. And nowadays, due to this lifestyle change and related stress, these sleep-related problems are increasing. And if someone is sleepy or there is excessive daytime sleepiness, then you can understand that there is chance of a increased risk of accident, poor job performance, and other health-related problem. And these health-related problems are both physical and mental. This also affect their reproductive health, that is their menstrual. They face many kind of menstrual problem. And EDS, excessive daytime sleepiness is associated with poor sleep quality and poor sleep hygiene. My objective of this study was to determine the prevalence among the female students of determine the prevalence of excessive daytime sleepiness among the female students of All India Institute of Hygiene and Public Health, and to examine the factor associated with EDS or excessive daytime sleepiness. To do this, I did a cross-sectional institute-based observational study, and it is a census study. That means I have included all the female students of our BN campus, All India Institute of Hygiene. All the female students were included. And we used a questionnaire, pre-tested, pre-designed questionnaire, which included the other the tools like sleep hygiene index, Pittsburgh sleep quality index, hospital anxiety and depression score, scale. And for this, we used Ipsword sleep result. In ESAs, we have scoring like so. So total 10, then we can say that there is no excessive sleepiness. And if it is greater than 10, then 10 or greater than 10, then it is excessive daytime sleepiness. So in my study, I found that 34.1% of all female students of hygiene, they have this kind of excessive daytime sleepiness. Their mean score was 7.77 and the standard deviation was 3.95. And you see there is another categorization, that mild EDS, that the ESS is 10 to 40. The 20%, almost 20%, 1/5 of the student have this kind of thing, and moderate is 9%, and severe is 4.5%. Coming to other variable and proportion, you see age, if the person is below 25-year-old, there is more chance of EDS compared, that is 37% compared to 22% in elders. And if urban residents, the chance of EDS is more. Bedtime, those who go to sleep before 11 p.m., they have no EDS. That group is only 6.8% of all participants have that thing. That is also a point to be noted, that only 3% of this, all 6% of this participant have go to bed before 11. And sleep hygiene, you can see the sleep and hygiene, if it is maladapted, then the percentage increased to 44%, and where if it is adaptive, that is 0% only. Sleep quality also that thing. Anxiety, depression, both have if they are at risk with anxiety or depression, then there is more chance of EDS. Other studies, they have found that the EDS range from 10 to 50. Some studies are done on medical students that more than 50. The medical students or resident, they have the excessive daytime sleepiness more than 50. And some studies are done in Indian college student that that is 32%. That is done in 2017 by Kaur and Singh. And all these studies, more or less, they found that this excessive daytime sleepiness is more who have this kind of bad sleep quality, maladaptive sleep hygiene, late bedtime, late awake time. Only thing is that they found that obese people have more sleepiness. But in my study, I found that it is almost same, that is 31% and 36%. So we can conclude that the 1/3 of female student of All India Institute of Hygiene and Public Health have excessive daytime sleepiness. And recommendation is that if they can improve their sleep hygiene, then they will get a better sleep quality, and that may help them to overcome this excessive daytime sleepiness. Ma'am.
Dr. Moshmi, it is a very interesting study, and considering that 1/3 of the female students in PG Institute of Kolkata are suffering or undergoing excessive daytime sleepiness, what recommendations did you make to your institute?
Ma'am, I already told that we and recommendation was to that this sleepiness is related to poor sleep hygiene and poor sleep quality. Now, sleep hygiene is the behavior, some behaviors which promote sleep. Yes, ma'am. And some behavior that we should avoid to that interfere with the sleep. So after this study, I make a arrange a meeting to convey the result that these are the results, because they are all of my students of my institute, and we discuss how to improve the sleep hygiene. Because if sleep hygiene is improved, there are studies that suggest that if your sleep hygiene is adaptive or hygienic, then your sleep quality will be improved. So if the sleep quality is improved, that means the person is sleeping well, then there is less chance of excessive daytime sleepiness. And I also explained them how they are this, if they do not correct this, they do not correct their, they continue to do this kind of sleepiness, then it will also affect their other problems like PCOS or obesity or other health problem. So I recommended that, and we also conducted a meeting to about the result and how to we can correct this. And others, my colleagues are did the other study related to sleep quality, sleep hygiene. And as far I know, someone is doing some, because this questionnaire that they are doing on community sample, the questionnaires are big, so they cannot include all the items if they are going for this community survey, because these are lengthy questions. So main
It was a very informative. It is very informative study, and you must make recommendations because 1/3 is a sizable number of students.
Yes, ma'am.
You should also look for other confounding factors, like maybe if stress is too high or workload is too much, because probably those factors I don't think you have looked into. If there is any
That is
confounding factor, you should look.
No, I have.
Yeah. Okay.
Ma'am, I have included the anxiety and depression thing score. So if there is, they have more chance of developing depression or anxiety. They have more this kind of sleepiness. So that is also related to sleep. Now, whether this is causing the sleep disturbance or sleep disturbance is increasing, that we cannot say from a cross-sectional study. So further study is also recommended to confirm which one is which comes first.
You may also recommend relaxation techniques like meditation and yoga. It would help
that is part of
in reducing weight
hygiene.
and decreasing anxiety and stress also.
Yes, ma'am. Ma'am, that is a part of sleep hygiene that at least 4 hours or 2 hours before we should stop doing some exercises or doing something stimulant activity like playing game or watching TV or mobile. Then that is a part of one of the light, and there should not be noise. If there is noise, we should do something about the earplug or something. So these are part of sleep hygiene. So I have recommended those things.
Thank you, Dr. Moshmi. It was very informative. Thank you.
Thank you, Dr. Mosmi. Now I guess we are done with the presentations for the day and we can end the session. Please, everyone, I would request you to join for a valedictory function. The link for the valedictory function have been shared in the chat box. Ma'am, it would be nice if you would also join us. And I would request all our participants also to join us for the valedictory function. Thank you so much, everyone. Thank you so
Dr.
much.
Nandita.
Thank you so
Thank
much, ma'am, for sparing your valuable time and gracing the occasion. Thank you so much, everyone.
Thank you for inviting me. Thank you.
Ma'am, it was our pleasure to have you amongst us. Everyone, please join the above link mentioned in the chat box. It's a request. Thank you, everyone. The participants are requested to leave this hall and join the plenary hall for the valedictory function. Thank you, everyone.